So, okay. Hello, everybody. Lots of great friends in the audience, and looking forward to working with all of you on this project. I'm going to open up the meeting today. I'm not calling us to order because we're not a committee. We are a task force, just a little more informal. And I'll talk about our process in just a minute. But I am going to ask each one of the task force members to introduce themselves. But I also want to remind everybody, if you're on the dais, you have to press the button and speak into the microphone so that it appears on the somebody needs to fix that. So that they can hear it on the recording. And for those of you who are on Zoom, you'll need to unmute yourself when you speak. And so we're going to go ahead and start on this side. Jackie, why don't you go ahead and start us off? Dr. Ward.
Yes, good morning, everyone. I am Dr. Jackie Ward. I am the System Chief Nurse Executive and Senior Vice President at Texas Children's Hospital in Houston and here in Austin. Glad to meet you all.
Good morning, everyone. Thanks, Victoria, for leading this task force. John Zarwas, the Executive Vice Chancellor for Health Affairs for the University of Texas System, former member here for about 13 years, and glad to be back.
Yeah. Do I need to move it? Okay.
Hi, I'm Kathy Thomas. I am retired from state service very recently and was the executive director of the Board of Nursing. I was with them for 34 years. So I bring a regulatory perspective.
For those of us who have not ever been on this side, we're going to figure out how this works. Okay, we're going to work through the folks who are online. If you can unmute yourself and introduce yourself. We'll start with Dr. Valerio from South Texas College.
Good morning, everyone. Great to be here via Zoom. Again, my name is Jason Valerio. I'm the Dean of Nursing and Allied Health at South Texas College, and I've been in the academia for about 26 years. Thank you.
Thank you so much. And is Olga with us?
Good morning, everybody. My name is Olga Rodriguez. I am the Chief of Staff and Vice President of Operations at the Texas A&M Health Science Center.
Thank you, Olga. Dr. Rice Spearman.
Good morning. I'm Dr. Lori Rice Spearman, President of the Texas Tech University Health Sciences Center, former Dean of the School of Health Professions, and I've been in the world of higher ed for about 40 years.
Cheryl Peterson.
Good morning. I'm Cheryl Peterson. I'm the Senior Vice President of Nursing and Patient Services, Chief Nursing Officer with Cook Children's Medical Center, and I'm also the President-elect of the Texas Organization of Nurse Leaders.
Okay. Jack Dwyer.
Hi, yes, I do many different things, but I own a $5 billion bank in Baltimore that lends money in the healthcare space, nursing homes and assisted living. But most importantly, I own 65 nursing homes in Texas under the Regency Healthcare platform. And most recently, I sold the buildings to a nonprofit called the Jack and Nancy Dwyer Workforce Development Company. So the goal is to solve systemic poverty by going into underserved neighborhoods and show them this fantastic career path in the nursing home and the assisted living industry. I'll pay for their training. I will help them. Usually they have other issues like childcare, transportation, housing. I'll pay for that. If they stay at the company that I place them at, because I have people all throughout the country, including not just my nursing homes in Texas, but all throughout Texas, other clients. If they stay there for more than a year, I'll pay for their college education to become an RN. So it's really, I've been in this industry for a really long time, and I know the issues, and they've been outstanding for 20, 25 years, and they got worse with COVID. So I'm here to solve it, and I just single-handedly do it myself if I have to. But, the bottom line is all the profits associated with the 65 nursing homes go towards executing on that mission. So it's a really innovative thing. And I think, that's what, the governor, put me on the board, and, it's really important. And I'm looking forward to working and hearing all the great ideas that everybody has, and to try to resolve this issue.
Thank you so much for being with us. Jamie Dudensing.
Hi, I'm Jamie Dudensing. I'm the CEO of the Texas Association of Health Plans. I also happen to be a proud graduate of Texas Tech School of Nursing.
Really great to have you with us. Dr. Cerise.
Hi, good morning, Fred Cerise. I'm the CEO at Parkland in Dallas. Previously was VP for Health Affairs with the LSU system.
Thank you so much for being with us today. All right, we're going to do a little bit of housekeeping to kind of talk through the process that that we have put together for this task force and to try to prepare this report. As you all know, we have been asked to help address the healthcare workforce shortage by the governor. And we are charged to investigate challenges to establishing and maintaining sufficient clinical rotation sites, clinical placements, and identify best practices to attract and retain qualified clinical instructors. We are charged to issue a report by October 1st of 2024. That's this year. That's in a very, very short order. So we have to sort of do a lot of things in a very short period of time. As I said before, we are not a legislative committee. We do not have to have a quorum. We do not subpoena anybody. We are going to sort of loosely follow some rules of order to make sure that we have a good, solid discussion. So, press your button and we'll recognize you to speak. And for those of you online, sort of unmute yourself and holler at us, and we'll make sure that you get to ask any questions that you have and speak. We will be bringing in lunch in the back, but we will not break for lunch. So for the members and the staff on the dais, we'll go sort of one at a time to eat, but we will continue the process through. I think we probably have a 4 to 5 hour sort of schedule today of given all of the presentations that we're going to hear. Right now, the task force is currently scheduled to meet 3 times. And we are going to, as much as possible, make those as public as possible and try to record those. We will announce them on a website. The task force has its own website now with the Higher Education Coordinating Board. And so we will put the meeting dates on the website and make the link. They may or may not always be in a hearing room. We're still working with the House and the Senate to make that happen. Want to shout out to the Senate. Thank them very much for letting us use this room. And we will post all of the presentations that are given. We will post a summary of the meeting, and we will post the video so that a link to the video so that folks can find and access all the information that they need. Our staff resources that we have, Miranda Goodscheller here is with THBI, Sydney Gaitan with Higher Education Coordinating Board, Donna Carlin, and Elizabeth Meyer with the Higher Education Coordinating Board. If y'all have any questions, just please feel free to reach out. I think the first step towards getting that report done on October 1st is kind of clarifying and defining the scope of what we're going to look at. So I'm going to talk about that in just a minute. I do want to say as my last note on process, we will be taking public input into this process at the second meeting of the task force. And so anybody who wants to give a presentation, anybody who wants to come in and talk to us about whatever idea and great idea you have, we would love to hear it. We have done a survey of the task force members as well as the advisory committee members. And so we're getting their input as we go along. But we also want public input from anybody who wants to present. So that will be at our second meeting, and we'll get that information posted as soon as possible. But for y'all's preparation purposes, that's when we will be taking public input. So primarily work will be done through this process through our what we're calling our work groups. Like I said, we had to narrow the scope or define the scope of what this project was going to look at. And we came up with 3 core and key topics for the report. Yeah. We're gonna kind of put the first one up, and you could skip what did I just do? There we go. Next slide. Next slide. I'm aware. Okay. All right, there we go. Okay, so the first work group, we're going to focus on expanding the pipeline. I do want to start. I think we all know that in every single healthcare profession in the state, there is a shortage of healthcare professionals. 237 of Texas's 254 counties are officially designated or have some officially designated healthcare professional shortage area in health, dental, or mental health. Clearly, all of those shortages are important and worth looking at. But in the short time frame that we have, we had to start somewhere, and we decided to start at the beginning. And that is with some of the beginning stage, the people that you encounter first, most often in the healthcare system. And that is the licensed certified technicians and certified healthcare professionals that you meet up in every single healthcare facility there is. And then nurses and those folks in the nursing profession. So expanding the pipeline, work group number 1 is going to identify those roles and examine the preparation and education and certification of processes for professionals that are working in the healthcare system. So since I got appointed to this, I now ask every single person who I see in a healthcare facility site what their background is and where they came from. I learned recently about medical ophthalmologic technicians. I mean, there are more kinds of technicians than you can imagine in the healthcare system. And every single day in every single facility, every medical practice, they are taking on greater and greater roles. I called this expanding the pipeline, but I really, in my mind, it's like the gateway to the healthcare professions. So a lot of people will get their first job in the healthcare profession with that initial certification and then progress throughout their career and get higher levels of degrees. So I thought it was worth taking a look at that role. We're going to hear from the Hospital Association today about shortages that they're facing in those professionals, and just taking a look at what we can do to get a handle on where the state of Texas is with regard to those kinds of professionals. The second work group is really going to be looking at modernizing the production model. And Commissioner Keller is going to talk to us a little bit about this. This is a part of the original sort of vision and thought process behind conducting a process like this is we address the nursing shortage in a lot of ways, and we have it many times, usually by addressing the choke points in the process. The idea with this task force is to take a step back and make sure that the whole process is where we need it to be to address the future of healthcare workforce needs. And so work group 2 will be reviewing the preparation of nurses, considering both the curriculum and the clinical training, and determine whether those competencies best prepare Texas students for the new and future realities of the healthcare workplace. Work group 3 is looking at, I think one of the biggest challenges that we all are aware of is the difficulty in finding faculty, particularly since the pandemic, and preceptors to help with training in that clinical space. Clinical training is really important, and finding the physical location and the expertise and the time and space to do it, I think is a real challenge. So work group 3 will study and identify barriers and opportunities to increasing the faculty pipeline for nursing and other health professions. In addition, the work group will review the other innovative models that could be beneficial for increasing the faculty pipeline that will serve the needs of a healthcare system and ensure healthcare workforce is reflective of all Texans. Part of that last sentence really talks about, like, what does AI mean? What does telehealth mean? So maybe technology is going to help us out in some of this capacity. Those are the 3 work groups. Each work group is scheduled to meet for 1 full day workshop. So we have 63 subject matter experts who are on the advisory committee to advise and help with this task force. Those individuals, the list of them will be put on the website. Those individuals have been divided up into 3 work groups, generally pretty evenly, 20 to 22 people for each work group. And so they've been asked to serve for 1 full day meeting in a very workshop setting. We're going to hear presentations in the morning from some of the stakeholders, but then we're going to, after lunch, break up into groups. We're going to consider research questions and really kind of work through the problem solving efforts that you kind of have to work through to come up with new suggestions and new models for the process. So those meetings will not be live streamed. They're not really going to be conducive to putting them online or for other participation. They will be invitation only. Task force members, the advisory committee members, and then invited speakers will all be able to participate throughout the day. Summary of those meetings will be prepared and put up on the website. And then we're going to ask 2 members from each work group to serve as co-chairs, if you will, and they will come in and present the findings of the day to the work group or to the task force, so that those task force members who can't be there can hear about that work and those findings. We will have virtual attendance at the workshop. It will not be the same, but we will make sure that those who can't physically be here can still participate. Task force members and work group members may be asked to present. They may be asked to participate as facilitators. They may be asked to be note takers or researchers. And then I will follow up after this meeting with task force member or work advisory committee members to ask about serving as co-chairs. That was a lot of the process. Are there any questions that anybody has from the task force about the process? Great. Okay, so we're going to now start with our presentations. Actually makes the day go a little bit quicker. We will start with a presentation from Commissioner Keller. Commissioner Dr. Keller. And Chancellor.
Good morning, Madam Chair and members. So I'm Harrison Keller. I'm the current Commissioner of Higher Education and CEO of the Texas Higher Education Coordinating Board. Of course, many of you are very familiar with the Coordinating Board, but our mission is to be a resource, a partner, and an advocate for Texas higher education. I don't really have a presentation, but did want to make a few very brief remarks to the task force, just to put it in context of some of our broader work at the Coordinating Board, and especially our work around our state strategic plan for higher education, which is called Building a Talent Strong Texas. So we have ambitious goals that we've set for higher education in Texas for increasing our educational attainment across our entire working age population. But Texas is the only state that's put down a marker that we don't just want to increase our educational attainment generally, we condition those goals on those credentials being credentials of value in our Texas economy. And they're of value because they're valued by Texas employers. And of course, in particular, we have urgent healthcare workforce needs. As the members alluded to earlier, this was an issue before the pandemic. Of course, it was exacerbated by the pandemic, but it continues to be a persistent issue. So nursing continues to be our number one critical healthcare workforce need. And we have a number of strategies that we've deployed, we have scholarship programs, we've got loan repayment programs, and to be candid, we don't seem to be making much progress. You can always do more scholarships, you can do more loan repayment programs. But the genesis of the task force in consultation with the governor's office was to assemble some of our state's leading experts, folks who bring a variety of different perspectives to put new ideas on the table about how we might not just double down on the conventional strategies that don't seem to be working for us, but how we might be more ambitious as a state in realigning our incentives and rethinking our production pipeline. Madam Chair, as you suggested, we have now multiple pathways into nursing, new kinds of credentials that have been created that can be stacked with other credentials along the way. Our nursing programs are already deploying technologies and have innovative partnerships, innovative pathways into and through nursing. So we have a lot of examples of promising practices. We often struggle to take these to scale. So, so one of the ideas behind the task force was to help identify some of these practices and think about what kinds of incentives might need to be in place, what kind of support might need to be in place so that we can scale more effective practices and meet the state's urgent healthcare workforce needs. So finally, there's one other issue I'd like to put on the radar screen if I could, as you're considering your recommendations. Of course, what you've laid out is a very ambitious charge, a broad charge, ambitious scope of work on a very tight timeline. And I don't think the expectation is that you have the silver bullet and the solution that if it could just get dropped into a bill or the Appropriations Act, that it will solve our healthcare workforce problems. Instead, the idea is to rethink what kinds of incentives, what kind of programs do we need so that we can head in a new direction that really does address these issues. And as part of that, so I'd urge the committee to consider what kind of structure we might need in place to help drive continuous improvement along the way. So instead of sort of a one and done solution from a public policy standpoint, how might we draw on insights from healthcare improvement and treat our nursing workforce and our healthcare workforce problems as themselves being public health problems and bring our best thinking from healthcare improvement to bear on this. That would include having some kind of structure to collect data, to share practices across our different institutions, and strategies to drive improvement over time. So I just wanted to say again, thank you to the members of the task force for being willing to take this on, to share your insights and your expertise. Our team at the coordinating board is all looking forward to supporting your efforts over the next few months. And thank you for the opportunity to speak with you this morning.
Thank you so much, Commissioner. Any questions for the Commissioner? Yeah.
Thanks, Commissioner. Appreciate you being here.
Thank you.
What's your sense on the timing that we've had, is how much time we've had to see some of these things be in effect? I know some of them go many years back.
Many years.
And they were well received, and I believe there was an impact, but obviously since then we've added 1,000 Texans a day to the population. We've seen continuous increase in the number of opportunities or needs for nurses out there. It's almost like, yeah, they had an impact, but we haven't been able to keep up with the need out there as opposed to them not having an impact.
I appreciate your point, Dr. Zerwa. So I think a couple of things on this. So one is, we're the fastest growing state. We've added more Texas residents than any other state added residents of the last 10 years. We've got a young and dynamic population, and generally our higher education systems and our nursing education, our healthcare workforce education systems were really set up to design to address a different set of problems for a different time, right? So really what we have is a system that might have been better suited to the kinds of challenges we were facing decades ago. And so we have to think about, well, how does the if you will, talent production pipeline need to look different for where we are as a state today and where we're going? How do the incentives need to look different? How do we better identify and engage talented students earlier in the pipeline? How do we scale our most promising practices and uses of technology? How do we have multiple pathways into the profession where folks can stack credentials along the way and cycle in and out of our educational programs? And then we know we have an enormous pinch point around clinical education, where we've got to be much more creative about what those clinical placements are like and make sure that folks are transitioning into the healthcare workforce in a way that they're well equipped and going to be able to retain. So that takes a different underlying infrastructure, different set of policies, different set of incentives to address our 21st century workforce needs.
Yeah, I would on one of your last points there in terms of finding clinical opportunities for them once they get their didactic education and so forth is definitely a choke point in the thousands of nurses that we graduate every year. They really scramble to find those slots for various reasons out there. And I would say that I defer to my nursing colleagues on this, but I think that from our standpoint has been a focus in terms of trying to really facilitate those better clinical opportunities once they get their didactics, because they're really almost kind of left on their own to figure that out.
Yes, I would agree with that. Thank you for your work, Chancellor Keller. I do think there's an opportunity for administration within hospitals to really double down and think about how we open up more for those clinical practice settings. I also think as a nurse of 30 years that COVID didn't do us any justice as a nursing profession. And I do believe that as we work for the pipeline of the future, we also need to think about how we rebrand nursing. And to be able to attract those students early on, like, are we creating bridge programs at the high school level to where the dual credits from a healthcare perspective? I know we do it for a lot of other industries, but I do think some of these other ideas will be appropriate, but infusing the rebranding of what nursing really is and what it isn't based on what we saw in COVID, I think is a strategy that we should really focus on to be able to change the thought process of what nursing is right now.
I appreciate that comments. And on the issue of the dual credit and dual enrollment programs in particular, so the task force has some new tools in the toolbox at your disposal to consider now because of the passage of House Bill 8 this last session. So we have new statewide scholarships for dual credit and dual enrollment programs. So students who are eligible for free or reduced lunch can take those courses at no cost, no tuition, no fees, no textbooks, no cost. And also there's now we have to implementation already an outcomes-based community college finance system where the community colleges aren't funded just on individual courses they offer in these dual credit courses, because they're the vast majority of the dual credit is offered through our community colleges. But they receive funding for students who take 15 hours of dual credit or dual enrollment that can apply to an academic or workforce credential. So that creates opportunities and incentives to have much more structured pathways, more coherent pathways that would come along with advising. So students aren't just taking courses more randomly, but they've got a clear line of sight into nursing, into other healthcare professions, and are already on that path even before they've left high school.
We have a question from Dr. Rice Spearman.
Yes, Commissioner Keller, I just want to thank you for your continued advocacy around formula funding. As we move towards this technology enhanced healthcare ecosystem, on the higher ed side, we are trying to build that same type of environment in our simulation centers. We're having to hire entire workforce around standardized patients so that we can be innovative on things that we can do around clinical training, preclinical training that allows us to be a little more creative with our clinical training. That's going to be essential. This is going to take a multi-prong approach, and we've got to make sure that higher ed has the resources it needs to be able to answer this call. So I just wanted to say thank you for your advocacy around formula funding.
Thank you. I appreciate those comments. And it certainly we need to make sure that the resources are there. And to your point, our formulas generally assume pretty traditional modes of delivery. We generally are funding more on inputs and seat time, as opposed to the outcomes and that are being produced by the institutions, and also really supporting and clearing regulatory brush to encourage the kind of innovation that's already underway across our institutions. So in this and other areas with our universities, with our health-related institutions, my hope is that as we go into this next legislative session, we can make a strong case for those resources and for more room to innovate these programs to meet the state's needs.
Thank you, Commissioner. Are there any other questions online from the Zoom folks? Okay.
All right.
Thank you very much,
Chair.
Commissioner. Good luck on your way to the airport. You can do it from here. Great. Okay, so our next presentation is going to focus on nursing. We're going to hear from the Board of Nursing, and we're going to start with Kathy Thomas. As I said, the task force members might be asked to present. So Kathy is going to be our first guinea pig and talk to us about the current state of nursing.
Good morning. I'm really pleased to be here this morning and to be a member of the task force. I'm looking forward to the work. It's going to be exciting. I'm going to talk today, next slide, about some of the trends we're seeing in the nursing workforce. I'm going to talk about workforce studies that have been done. And lastly, I'm going to talk about a discipline issue that has occurred with the Board of Nursing called Operation Nightingale. All of these things may impact the future workload of the agency as well as the profession. Next slide. This first slide, I just want to say to begin with that we have had historical shortages in nursing forever in the state, right? And other states as well. During World War I, during World War II, there were huge shortages. But of course, we've had them with hurricanes and of course the pandemic. It's important to recognize that even when there haven't been shortages in certain areas, metropolitan areas, for example, there may be medically underserved areas within those populations, and also our rural areas that have always had some shortage, right? So it's a very fluid thing. It's very dependent on the area of the state that we're talking about. But in general, there's a couple of factors that affected the shortages over time. One of them is the Texas population. We have seen a growth of about 470,000 people in the state since 2021. That's huge. It led to a greater demand for healthcare services, for nursing in particular. And we've seen that both in the face of a shortage and in the normal growth that you will experience in healthcare. It's also due to the aging population, which we all hear about all the time, and we look around and see it. The nation's elderly are living longer and they're managing more complex health issues. What does that mean? It means they need more nursing care. We've had various shortages during weather events. Harvey was a big one for us in that we needed specialty nurses of different types during that time period. It was very difficult to get them. And those of you on the provider side or the service side realize that. But I think it's important to say that in 2019, before the pandemic, we had a 5% turnover of registered nurses and vocational nurses in healthcare facilities. And our median turnover rate was 18 to 19%. So it was already headed in that direction in general. You're going to hear more about the shortage and very specific data from Pam Lauer with the Center for Nursing Workforce Studies, and I'm going to defer that to her. If you look at this slide, this is the slide that illustrates the growth in RNs and the loss of LVNs, really. So in the 2023 year, which is the most recent data on the far right of that screen, you see that we grew about 5.7% of nurses, RNs, and that wasn't particularly helpful given the need. Okay. The LVNs, on the other hand, have shown a slow decline in the population since 21. And although the 22-23 decline was only 0.5%, you can see that there's been a steady movement in that direction. And I think it's important to say that this trend has been going on nationwide, not just here. The next slide shows APRNs. And on the other hand, APRNs have grown dramatically. What we see is if you look at the last 5 years from 2019 through 2023, you'll see that we've had a growth of about 58% of this population, which is very much needed and a good thing. The largest number of APRNs is still nurse practitioners, followed by CRNAs or nurse anesthetists, followed by clinical specialists, and lastly, nurse midwives. But we're not going to know what the 2024 data show until the end of this fiscal year, which will occur in August of 24. That's when the 24 year ends. Following that time, there's a lot of reports that go on and massaging the data to make sure we're accurate on that data. Next slide. This is a slide that shows the current discipline in Texas, just to balance things out a little bit here. It affects a very small population of nurses in the state. Right, this year, this past year, it's been 0.28% of registered nurses and 0.6% of LVNs, while APRNs are about the same as RNs, 2.27%. And that represents a very small number of people who have discipline within the year. So everybody else who's finished with it, it goes away. Next slide. These are the type of complaints that the board receives. And, you know, over half of them, if you look at the top 2 bars, have to do with drugs and alcohol. And they are, you know, fitness to practice, deception, misappropriation, those kind of things. These problems, as in the general population, grow, okay? Particularly as the number of nurses grows. And they're not different from that general population group. While the practice issues that you also see in the lower yellow bar are only 21% of the complaints that are received. And, you know, only a certain percentage of those have actions taken against them, but result in some kind of investigation. So I think it's important, if you look at all of the bars, you'll notice you're over 100%. Well, the reason is because most complaints involve more than one thing. Okay, it may fall into one category, but not all the categories. So you'll see some duplication there. Next slide. You probably know that that Texas has been a member of the Nurse Licensure Compact for, well, since 20,000, long time ago, 24 years. But in 2015, the group began a discussion about what would it take to get more states to join, because we sort of plateaued at that point. So the National Council of State Boards of Nursing convened a group. They came up with a new compact that would help certain states join, right? And also were identified as problems in the original compact. It's not unusual for any compact, whether we're talking about river water or access to that water or licensure. Those compacts always periodically look at what they've learned during the interim and make changes to their compact. So this was done in 2016, 2015, and not implemented for a couple of years. So Texas adopted the new compact in 2018, the beginning of 2018. And states have adopted it since that time. What the compact does is allow anyone to practice on one license, a multi-state license, in any participating jurisdiction. But it also gives states the authority to take action if something happens in their state, either on a multi-state license or a single state license, that happens. And if a person has certain exclusions to a multi-state license, those would be primarily criminal conduct of some kinds and disciplinary action in another jurisdiction. The compact provides that those are not eligible for a multi-state license. The differences in the two compacts are many, but I'm going to highlight just a couple of them. One is that uniform license requirements were added because it was felt that needed to be articulated for all the states who join. Certain criminal conduct wasn't eligible for the multi-state license, and then federal background checks were required, which Texas had already been doing. Now, during the pandemic, we had a little bit of experience with opening the doors to nurses from other states in good standing, which meant there was no current discipline on their license. But we did have a couple of situations where nurses came from other states, were reported for misconduct in the workplace, and there may have been a lack of jurisdiction in those cases. So that was added to the new compact. There are 42 jurisdictions that have enacted the new revised compact. We just added the 42nd state, which was Connecticut. And you can see it's passed, but not yet implemented. So if you look at this map, gray states are those states who have not adopted the compact. There are certain new states that are in the process of implementing, but that's to be expected. And that leaves 10 states and 2 territories that haven't joined the compact. Right now, there are 40 states and 2 territories that have joined. So that's the status of the compact.
Kathy?
Yes.
Because you were involved in the industry throughout that time, do you feel that joining the compact made a positive difference in the supply of nurses in the state? And do you think it's where the compact is where it needs to be?
Well, particularly with the changes in the new compact, I think we achieved a lot of addressing the concerns that were out there that we had, as well as other states.
Okay.
So I don't think that means the compact will be stagnant forever. It'll always be reevaluated to see if there's anything else we can do at this point. But I think for the most part now, we're very satisfied with the compact. It's screening out the people that need to be screened out, but it's allowing for a lot more cross-state practice, particularly with telehealth. That's been a huge help along the border,
Okay.
as well as in our rural areas.
And do you feel like some new nurses came to Texas because of the compact? Do you have a way of knowing?
Yes, we do feel that, but we don't have data to support that right right now. But yeah, I think it makes it more attractive, particularly for military families. If they have a choice of assignment, they want to pick a state where they don't have to get a new license.
Okay. Great. Thank you.
Especially for spouses, yeah. Okay, next slide. I'm going to give you a little summary of the national workforce studies that have been conducted by NCSBN and the Forum of State Nursing Workforce Centers. They do this in collaboration every 2 years. The last one was done in 2022, and the results were published in 2023. So we're already in a 2024 year, and they're beginning to collect data on the next set of workforce surveys. So we got about 300,000 nurses to participate in this particular study. And the questions were expanded to include things like the minimum data set, which is established by the forum, the practicing in telehealth and to what degree, compact retirement, travel nursing, direct care, and COVID-19. So all of these things were examined in the workforce studies. I think the next slide shows the registered nurse updates. These results, if you look at RN and LVN, are fairly similar, but I'm going to highlight them separately anyway. Some of you are more interested in what the RN status is, but both are provided here. So for the registered nurses, in both the RN and LVN one, you'll see the average age is about the same, 45, 46, which is much lower, and it's coming down as older experienced nurses leave the workforce and retire or just stop nursing. Okay. We have 71% of RNs who have a baccalaureate degree in nursing or higher. That's a pretty pronounced step. It's been a goal, and it's achieving success in that way. And this is national, remember. RN salaries are up, as are the LVN salaries. And there is 50% of nurses now that practice telehealth. And in general, you see that for RNs and LVNs, surprisingly. So video calls, or I'm sorry, first of all, RN clinical or electronic messaging increased from 24% to 32%, pretty significant. And the video calls tripled, 11% to 35%. So that's really big. Over half of the nurses, RNs, report increased workload, and you'll see that in the LVN population too. And 15% changed their practice setting. 8% or almost 9% retired or left nursing, period. And 46% said they felt burned out. And that was a big increase over the prior survey. And of course, we know how COVID played into that. If you look at the next slide, this is the vocational nurse results. And the average age is about the same. They lost 60,000 nurses during that time period. The median LVN salaries increased, and over 50% practiced telehealth with the same number, triple video, use of video for telehealth, up to almost 31%. And then 62% reported their workload was increased, very close to the RNs. 11% changed their practice setting, a little bit lower, and 10% retired or left nursing, period, and that is higher than the RN population. 45% said they felt burned out, a common theme that you're going to keep hearing. So the key takeaways, next slide, from these workforce studies. In the wake of the pandemic, nursing workforce has undergone a dramatic shift. And they've lost hundreds of thousands of experienced nurses across the country. The workforce has become younger and more diverse. That's good. So we have greater number of Hispanic, Latino nurses and male nurses, and we really need more Spanish Hispanic and Latino nurses in this state. Male nurses are seen as sort of an untapped area for expansion. An increasing portion of the RN workforce holds a baccalaureate degree or higher. That moves us closer to the National Academy of Medicine recommendations that have been made. And salaries are notably increased due to inflation and demand for nursing services, right? With a quarter of the population saying they're going to leave the profession, the impact of the pandemic is going to be felt in the future for a while. If you look at the end of that slide, you'll see there's a reference from Smiley et al. On these workforce studies that have been published in the Journal of Nursing Regulation. Next slide. I'm going to talk a little bit about Operation Nightingale. This particular operation has created a huge impact on the Board of Nursing and perhaps on the profession in the future. Next slide. So January of 2023, just a little over a year and a half ago, the Office of the Inspector General of the Health and Human Services Commission, federal, they and their enforcement partners, primarily the FBI, launched a multi-state coordinated licensure information action. They apprehended people who were in a scheme to sell nursing transcripts and nursing diplomas. These are for people who did not complete nursing education programs. 25 people were charged and indictments were issued for all those who sold the fraudulent credentials. Some of them are in jail right now or in prison. The Board of Nursing in Texas at that time received 200 names of individuals who had purchased or become licensed. Stunning thing to us. Never happened in nursing, even though you've seen these kinds of results in other professions or pseudo professions for years. You have not seen them in nursing. Next slide. So what is Operation Nightingale? This is really a summary of the scheme, just so you have it. It's again, the selling of these fake credentials. These are from Florida-based nursing programs, and I'll kind of tell you how we got there in a little bit. To those people who are seeking a license as RNs and LVNs, some of these individuals were not able to get into other nursing programs. And because they were largely from foreign countries, they didn't necessarily even understand what they were getting into. Some did. So the credentials were used to qualify these people to sit for the National Nursing Licensure exam. And that was a big step. Many of them failed the exam multiple times and continued to go through exam review courses in order to learn more about the exam. Upon successful completion, they would be able to obtain a license, which they did in some cases, and of course work as an RN and LVN. Now that's a scary thought because these are people who presumably did not go through a nursing education program at all. So they may be employed in a setting where there's not a lot of observation about what they're doing. They're kind of getting by. And some of them have been reported to the board for misconduct. Next slide. In Florida, they have an interesting scheme, but the Florida Commission on Independent Education is responsible for approving the programs that are not state-based programs, okay? And they license those schools. Okay. Now they work with the Board of Nursing, but their approval is independent. 2 weeks after the OIG apprehended individuals, so that's into February of 2023, that commission took action to cease the operations of various people or programs that are that were involved. And the reason that they did was that these individuals were also associated with the institutions in Florida that were named. Same people. Next slide. So following all of this, the Board of Nursing issued a web page that described Operation Nightingale. This contains public information about Operation Nightingale. And what it contains is things like, if you look at the slide itself, there are formal charges, disciplinary action, and denials that have been taken are listed there, and they're kept up to date. Any press releases by the feds, general information about the project, and so on are kept here. The Board of Nursing continues to work with other regulatory bodies, with the education program providers, accrediting folks, and they're trying to resolve these matters as quickly as possible through a legal channel that has a process for continuing cases and so on. If there is evidence of fraud, in other words, people knowingly were involved, the revocation of licensure would be sought in these cases. If you look at this website periodically, this will continue to contain more information about it. And if anybody has any concerns about any individual nurse, whether they know they went to a program like this or not, they can be reported through the complaint portal at the board's website. Next slide. Now, there were other programs in Florida that were not named in Operation Nightingale. And so the first question we asked the FBI is, what about these other programs? We're seeing that there's some similarities in these programs. And of course, they can't say anything about an ongoing investigation, just as we wouldn't be able to. So they are, they're quiet about it. But we became aware that there were similar programs and that those particular programs were not substantively equivalent to Texas programs. So we began to review their education, and that continues with the board now under special review. And these independent programs are located in Florida. They have a lot in common with the programs that were named, and they are being especially looked at by our nursing consultants at the Board of Nursing, which has resulted in a lot of denials. There's about 150 denials right now, most of which involve Operation Nightingale cases or like cases. Next slide. There is a rule that the board operates under for these special reviews, and it contains what Texas programs have to meet. And it's fairly generic information, but it's pretty easy to see that these programs do not meet this. And they might include things like clinical preparation. They might include clinical decision-making, patient care, experiences across the lifespan. They're often not found in these programs. Okay. Many of these programs recruit and market to LVNs in Texas. We're a big state. We have a lot of people here, and so they're specifically chosen. The programs generally have no clinical component at all. There are inconsistent histories between what the applicant tells us and what the program tells us. They don't talk to each other. They don't even know what the program required, and the program doesn't know what the applicant knows at that point in time. So several of these schools have now been closed because their pass rates are so low on the national exam. Next slide. These are the red flags that prompt the special reviews, and they're pretty obvious, or they have no clinical experience at all. They're completely online. They've never been to Florida for anything. Many were approved by the Florida board at one time, and as I said earlier, lost their approval. They have very low pass rates in the 20s sometimes. And individuals who are involved are also involved in these other programs, in the Operation Nightingale programs. Next slide. we are told by the federal agents who are involved that the individuals pay between 17,000 and 20,000. These people that, you know, have been trying to get into other programs and new to the country and don't necessarily have a lot of resources. Some harmful and incompetent practice has been reported to not only our board, to other boards across the country. Of those who are licensed, many applicants were licensed in other states, and then they applied for endorsement into Texas. They went to certain states that they thought they could get in under the wire, and then endorsement, which is an easier process, was applied for in Texas. There are ongoing federal investigations. We are told that we should expect more reports in the future and anticipate we'll get those in Texas. The FBI has actually hired licensed nurses to help them with these investigations. That's a good thing. And the board is aware of some of the endorsement applicants have gone on to complete other programs, sometimes a master's program or into BSN program. And we've been informed of that as well. Okay, next slide. During the last legislative session, the Legislative Budget Board and ultimately the legislature included a regulatory rider to our appropriations bill. And that regulatory rider permits us to, or the agency, to fund and hire additional staff during this biennium, which is 24-25. And we had to submit a finding that additional resources are needed. That was submitted and that was accepted by the LBB and approved. And so the staff are being hired right now. I'm happy to answer any questions you might have.
Thank you so much, Kathy. Are there, let's go to Zoom first. Any questions from anybody on Zoom? Okay, great. Anybody? Oh, wait, we do have some. All right. Yeah, Jamie, let's start with Jamie.
I'm sorry, it took me a moment to get my hand up. So I don't know this is a question for this exactly, but thinking about Harrison's presentation and this one, and then the speakers going forward. Victoria, I'm super interested in how many quality applicants are getting denied into schools because there's not enough slots available, and whether or not that's because of professors' availability or that clinical piece that Dr. Cerise was talking about.
Okay.
On that. And then I'm also very interested in that from that presentation, we're talking about that 8% of nurses leaving the profession with burnout. I would be interested in how many nurses are leaving the profession within the first few years after graduation on those pieces. And if we're able to have that. And I don't know if there's also any way for us to think about surveying or getting some of this data if it's not available on nurses who have recently graduated and entered the workforce, on why they're staying or why they're leaving so quickly. Because it's my understanding that we're losing quite a few within the first 3 to 5 years of them graduating from school.
I'll just take a quick shot at this. There may be others who can speak up more. The issue of denying license or denying admission into nursing programs, we have known is a problem for a long time, and other speakers may be better equipped to answer that question. But I think those numbers have been concerning for a while, in that programs accept the number of students they can accommodate, right? So if they can't, then they reject the students who didn't have the highest scores in the group or whatever. So that is a problem. And I'll defer to other speakers who might want to talk about those issues.
Okay.
I think burnout and the nursing recent graduates plans, I think those are the questions that need to be perhaps expanded in the survey, and I can forward that information on to the survey folks to see, and Pam or others may know more about that.
Those are good questions, Jamie. We'll keep them front of mind for some of our next speakers. I think that Pam will be able to give us more feedback on that too. So thanks for bringing that up. Okay.
I will add, Victoria, to that question about the 1 to 3 year nurses. Many hospitals have transition to practice programs. They are accredited. And that's a 1 year, 18-month program for graduate nurses to be able to transition from the classroom to the hospital. It is known that that 1 to 3 year timeframe is the critical point for embeddedness for new nurses. And we do see across the country where the turnover for that 1 to 3 year nurse is higher than your nurses beyond that tenure. So this is an area that I do think requires intentionality of understanding why are those nurses leaving either their hospital to go to another practice setting, or some are deciding to not be in nursing as a profession altogether. So that is a trend that we are seeing in the hospitals.
Dr. Cerise, you want to go?
Yeah, thank you. I have two questions. One, when you showed the graphs at the beginning, where the RNs were up about 5%, and the LVNs were flat or decreased a little bit, I thought you said, and I may have heard this wrong, that the RNs were up 5%, which was not helpful because that's not the area of need. And maybe I misheard that. But if that's right, can you elaborate on that a little bit? And then my second question is around the loss of 260,000 RNs and LVNs in the context of COVID. Do you have kind of a net number, like what was added during that time? Are we, did we lose ground, or are we treading water, or what's the net there? But the first one I was really interested. Maybe I misheard you.
The number of RNs, I'm making sure I understand your question. The growth in the number of registered nurses was 5.7%. And I think your question was, did you hear that right?
You did.
Yes.
Was
and
the
the reason-
comment that wasn't the area of need, is what I thought I heard.
No, it wasn't not the area of need. It was the fact that the growth in the demand was bigger than that. And Pam may be able to speak to that.
I see. Okay, that makes more sense. And how about, do you have a net number for that time period during COVID? Like what we added to the workforce?
Well, one of the trends we're seeing is that the people leaving the profession is going to have a huge impact on the supply. And this really reinforced that, even though it's a survey, so that it's not every nurse in the country reporting, there's sort of a projection on what that means. But those losses were not necessarily offset by any growth that happened in the population.
Thank you.
And Dr. Valerio?
Thank you. I just wanted to share regarding the study conducted by People Element regarding the 2023 nursing workforce, that according to that study, that 46% of the nurses are considering leaving their position in the next 6 months, and 22% have changed their positions in the past 6 months, and 13% of the nursing workforce are considering leaving the profession entirely. And with the same study, they also conducted the sentiments as to why these statistics are happening. And according to that study, they're leaving their job, it's because of unsafe nurse to patient ratio, burnout, inadequate staff support, and also inadequate training or onboarding process. Thank you.
Thank you very much. Any other questions? Thank you so much, Kathy, for that presentation. It's a good perspective on where the profession is right now. And I think this next presenter is Janice Hooper from the Board of Nurse Examiners, going to get a little more into the data for us.
Yes.
Thank you very much. I'm privileged to be here, and I do want to pay a compliment to Kathy Thomas. I was under her leadership for 21 years, and that was a real privilege. So thank you, Kathy. I'm Jan Hooper. I'm one of the 6 education consultants at the Board of Nursing, and we have the pleasure of working with the nursing programs in the state. My favorite thing to talk about is nursing education in Texas so I want to start by saying, well, how are we doing? 2023 pass rates were calculated based on the calendar year for 2023. And the pass rates for national level, as you can see, are in the 80s, and we far surpassed that for both RN and VN candidates. You'll see that we had about 15,000 RN candidates take the exam and about 3,500 VNs take the exam. So among the RNs counted in that were 124 RN programs, and 17 of those programs had a 100% pass rate. 83 had over a 90% pass rate. And if their pass rate falls below 80%, they're required to write a self-study. So 2 wrote a self-study for the 2023 pass rates. Texas is one of 3 states providing over 10,000 first-time candidates every year. The other 2 are Florida and California. So we really are great producers of nurses. For the PN or the VN, we call them vocational nurses in Texas. We had 86 programs that were in the report. 17, again, had a 100% pass rate, and 59 had over a 90% pass rate. 6 of the programs are presently writing a self-study. That self-study is to look at their program and examine factors that may have contributed to the lower pass rate. Yes, VN enrollments have declined since 2020. And some of that is because students are choosing to go on into an ADN program, but they're just not choosing to go into VN education. And this is a little bit of a concern because we're thinking in the future, LVNs are probably going to be used more in healthcare to help fill the gap because they are very well educated. The total number of programs we have in the state, we have 1 diploma program, Covenant Nursing in Lubbock. It's from the hospital-based program. 67 associate degree programs, most of which are in community colleges, 62 BSN programs, and the number of BSN programs has been increasing recently so that we're getting more prepared at the BSN level. So we have 130 total RN programs in the state and 86 VN programs right now on our list. This year, so far in 2024, we have approved 5 new programs, but 3 have closed. And a couple of those were VN programs strictly because their enrollments are so small. Okay, something happened in 2023 with the NCLEX, the examination to get the license from NCSVN. And it was that questions were added about clinical judgment. And this started in 2012 when the NCLEX committee studied the results of the practice analysis that's taken every 3 years for VN and RN programs to see what new nurses are doing, what they consider most important, and what they're doing most frequently. Because we really want the exam to evaluate whether the new graduates are ready to step into that level of practice. And it was noticed that all nurses, even vocational nurses, are making clinical judgments about their patients' care. And so we wondered, is it possible to measure clinical judgment in exam questions? So beginning in 2012, extensive research has been carried out to determine whether this is possible. There was a tremendous literature review looking at theories, looking at practice to develop a clinical judgment model. So when you're talking about making decisions, you're going through steps. This is the model. It looks a bit complicated, and I'm sure people can't read it very well, but it boils down to level number 3, 6 steps in making a clinical judgment. So here are the steps. First of all, look for cues. The nurse assesses the patient based on their knowledge and experience, based on their knowledge about assessing a patient, about all disease processes and symptoms. and also about reading the chart and listening to the doctor and hearing the report from the previous nurse. So that's their first job when they have a patient load and they go into practice. Secondly, analyze what's going on, reflect on all of these, and then prioritize hypotheses. What is most important to organize my care for this patient? This is not a linear process. It doesn't go straight from one to another. Sometimes then the nurse has to go back. I have to go back and look at this patient again. I've got to reevaluate this. But they generate solutions of what they're going to do. They take action and deliver that nursing care and then evaluate the outcomes. So those are the 6 steps in clinical judgment. So questions were developed on each one of those items. And they were tried out on students. They were evaluated. A lot of statistical analysis went on. And on April the 1st, 2023, everyone knew this was going to be the start. If you took the exam on April the 1st, 2023, you're going to get new questions. It's not the whole exam because all of the exam was wonderful, but this is looking at whether they can make clinical judgments. So the plan was to have 3 scenarios presented to each nurse, at least 3, and then they would have questions for that scenario that would take them through those 6 steps. And it was found this is quite effective. In fact, today, many students say they like it because it's just like practice. It's just like what they do. Programs had been preparing. As soon as we knew this was going to happen, we started preparing our programs and they listened. They did as much as they could. I think that's why the pass rate was over 90% for our state. This was for RN and VN, by the way. There was a new scoring set up for these questions because they were going to have multiple responses. They had to pick things out from the responses. So it was decided to award 1 point for correct answers and take away points for incorrect answers. So this would discourage guessing because you might lose points for guessing. All right, I'm going to switch gears now because I want to tell you about a survey that we took from the board of all nursing programs last December to get at what was going on in clinical. We knew that clinical was a very big issue and getting more difficult. So we surveyed all programs with a few questions for open-ended answers. About 1/3 of the programs responded in the quick 1-week deadline that we gave them. And the responses varied from being very short to very lengthy. Many of them wrote stories. They did tell us on their questionnaire that they greatly appreciated that we were looking into this matter and that they wanted to know what the results were. So one of the questions asked them, tell us about your most successful clinical experiences. And these are in the order of the most responses for each response. You can see the very highest one was to have settings with diverse opportunities so that students got a lot of different experiences while they were in their educational practice. Secondly, helpful clinical staff, willing nurses. To me, there's 2 sides to this. Students want the nurses to open their arms to them and say, come on in, I want to teach you everything and I'll take care of you. And the nurses want the students to come in and say, good morning, I'm your nurse. I will do anything that I can help you. I want to learn from you. You are my model. And they haven't quite made that connection. We know that the students today are lacking soft skills. And this is because they've been learning remotely. They've been on the computer. They have not learned how to walk in and say, good morning, Mr. Jones. I'm your nurse for the day. What can I do to start with? Instead, they're going in and they're saying, good morning, I'm your nurse. Text me if your heart was beating. So that doesn't work very well. And we're going to be working on that. Another thing is community settings. Experiences out in the community are so good. And I know you're all aware that there's such a shortage of clinical opportunities. And one thing I'll touch on is that programs have got to be out in the community looking for more practice areas, more ways they can be a nurse in the community. Clinical partner arrangements. Dr. Valerio is watching. At our next board meeting in a few weeks, he will be bringing a proposal to the board for approval, and it is for one of the structured Department of Labor apprenticeship programs that they're planning to start at South Texas College. This has been an opportunity for programs in our state because it has been determined that Texas is an apprenticeable opportunity to award some of the Department of Labor money. But it's very, very restricted, and it takes a lot of work to do the planning. There has to be approval of the hospital, there has to be approval of the school, then the plan has to be approved. Any monies that are sent to the state go through the Texas Workforce Commission, so they become involved. And then finally, the workforce wants board to approve the proposal. So we've had a few come before the board, and one will be coming this time. So good luck, Dr. Valerio. But it's another opportunity. Another way that programs can work with hospitals and develop more clinical opportunities is to establish a partnership where some of the students who meet quality criteria can be selected to participate in a partnership in the hospital where they do extra clinicals and they also get paid for their clinical practice. So it gives them a double role. They're a part of the setting, they're a part of the school, and the faculty are still responsible for them. They're still meeting clinical objectives. So that's something that is being picked up in more settings. This was recommended by NCSBN during the pandemic when suddenly the students were all taken out of the facilities and they were missed. So a lot of nursing organizations across the country agreed that such a partnership would be a wise thing to establish and to help provide care where they could. And it doesn't work for everybody. It's not everybody's interest to be doing more work, but it is one way we can get more nurses into practice. DEUs with some of the floors in the hospital are set up especially for a school. They have an agreement with them, and so they provide a lot of their clinicals, and the nurses all get to know the students. Simulation. Some years ago, I have to say it was really wonderful that the coordinating board had grant money to allow students to write grants, and many programs got a good bit of money to put into their simulation equipment. And that was extremely beneficial when the pandemic came along because a lot of things had to revert to simulation. And having clinicals with positive relationships between the clinical setting and the school. So we really stress to programs, you need to establish good relationships with your clinical facilities. And long-term care. It came to our attention some months ago that there are very few students use long-term care for any clinical experiences, and yet they can be great experiences. So a practice consultant and I got together and developed a guideline for how all programs can use long-term care in their clinicals at a certain level of what they're doing. And then she wrote a nice article for our bulletin. And we're trying to get the word out that don't forget to use these facilities. And then home health also is another great clinical opportunity. And those were all used. They were mentioned by the schools. Some winning ideas. I actually presented this to a big group of deans and directors, and I chose the best ones and gave them a little award, a little trophy for their ones. But this ones of taking students to a pediatric summer camp for critically ill or disabled children was a wonderful opportunity. It only comes once a year in the summer, and they actually hired a pediatric nurse practitioner to go in and be the faculty working with those students. Another one is hiring full-time faculty who also work in a hospital part-time. That sounds like too much, but I did that when I started teaching. I worked in a hospital on the weekend and I taught during the week, and it was the best of two worlds because my students went to the floor I worked on. So I hope they got a good education. Thirdly, director of nursing in a local skill facility providing orientation. They said they took the students, and the first day, the director of nursing in that facility met with the students and gave them orientation. And that was such a good beginning that they had the lead person talking to them. And students in health assessment class carrying out a head-to-toe assessment on each other with a health history. I mean, you have to be willing to share. But what a great opportunity to do something for the first time with one of your peers. And then students traveling to a distant city for clinicals. We have a lot of programs that say we can't get pediatric, we can't get maternity, but others get a bus and they take them all to a city, maybe on a weekend or for a few days, and they spend concentrated time on a particular clinical area. Some more winning ideas. How about pairing a junior level student with a senior level nursing student and having them work together as a team? That's one idea. Standalone dialysis center, let all students rotate through. I don't know that students use the idea that you can rotate all students through one observation experience during that clinical rotation, and they might get view of something they might not see otherwise. Then all these little clinical observations were mentioned. We do allow programs to use observation, not all the time, but as unique experiences where the student can go with a licensed professional and watch them in their role perform certain procedures. Now, these are the challenges that were mentioned, and you already know some of these, the competition of clinical space. They're all in competition. And I know some communities have a group of programs and hospital people that meet together periodically and discuss the needs and look at how they're going to provide the clinicals for those different groups. Lack of qualified faculty, and this is getting to be a bigger problem, but our rules actually allow for BSN nurses to work with MSN nurses on the floor with a few more students. And that kind of stimulates interest in that BSN nurse and becoming an educator, but provides more hands and more people working with students. Right now, it's a challenge in clinical because most facilities want fewer students with one faculty member. Our rules allow 10, but we're seeing a lot of settings and they want to go to 8, which that's probably a very good thing, but it makes it harder to place all the students. Willingness of nurses to work with students. And I'm really stressing you need to teach your students how to go in with the right attitude. They're not there to help you. You are there to help them. Preceptor availability. We are having a shortage of preceptors. We expect for RN students that it is an RN. For VN students, it could be either one. But many hospitals are hiring so many nurses, new nurses, that they're not quite ready to be a preceptor yet. Fewer sites for VN students. There are fewer places where VN students can practice. But we are seeing this move toward hiring more LVNs in hospitals to help fill the care gap. And we've had programs ask us, can we put our RN student with a VN preceptor? No, you can't do that, but they can work with that VN and they can help them in their care and they can learn the scope of practice for the VN. Faculty willing to work evenings and nights. Well, that's a little harder one to find. And then students are not motivated. We are finding, as the whole world is, that we've been through a lot with the pandemic, and it has caused a little bit less motivation. And hopefully we can turn that around. Opportunities to use the computer for giving medications and charting. This has been a little bit of an issue and letting students get to it. I was visiting the University of Houston some while back, and I went on a visit over to the hospital, and there were first day students there. They were already on the computer. How did this work? Well, they bring them in and they teach them, and then they allow them to immediately start using their skills on the computer. Ask the programs what clinicals best prepared your graduate to walk on the floor and start practicing. And I love the idea, Dr. Ward, of the internship program. I think you mentioned that. That's amazing. And the first thing, of course, the best practice is hands-on with patients in acute care. That's the very best. But simulation, right, is there at second. And I had been not appreciating how much simulation activities might help them to be on the hospital floor. Clinicals in multiple sites. They need a lot of exposure, faculty-led clinicals. And I know some research by NCSBN some years back found that faculty who taught didactic and then also took the students in clinical had the best results with their students. But we can't always do that anymore, so we have to use a lot of part-time. Skills lab and foundation skills, soft skills, preceptor-led practice. Students like being with a preceptor. Teaching tools, writing those care plans that took me 30 years to throw out. Post-conferences where you get into the talk. I've been telling faculty for years, you need to be talking to your students all the time. When you go in to see them with their patient, ask them what they're doing. Why did they decide to do that? What were they thinking when they did this? You know, just to get in their thinking so that they're stimulated to do more thinking before they do care. And then community involvement. Service learning is a possibility. There are community settings that would welcome having a student come in for a day and help with whatever they're doing. So we need to think outside the box, off hours, maybe 2 students to a patient. I think we're going to go back more into team nursing. So, you know, using teams is probably good. Home visits. I don't know if that's possible, how wonderful it would be if students could make more home visits and actually be in the home for a patient, especially when they're just discharged, to see what they're having to manage at home and how they're doing it. Seek alternate sites. And what else? You almost need a person in your program who can just be out in the community looking and talking to people, because it's those relationships that are going to get it made. Okay, I'm going to switch gears again. And I just want to say a few things about a study that was done at NCSBN, and that's the National Council of State Boards of Nursing. The boards all belong to it, and we meet regularly, and it's an amazing organization. But they did a survey trying to determine what are the quality indicators of nursing programs. There's no literature about quality in education. So there's literature about the outcomes, how many graduated, how many didn't graduate, you know, and things like that. Did they get a job? How satisfied were they? But those don't really tell you if it was a quality education. So this was done by a 3-pronged research. And we had so much data, thousands and thousands of bits of data. It took a couple of years for the researchers to put all of it together. But they came up with 18 quality indicators. This is my favorite part of the study. The study was actually a supplement in the Journal of Nursing Regulation. And if you happen to really be bored with life and you would like to read it, if you let me know, I will send you a PDF of that. I had the privilege of working on this with this group. It was incredible. But now when we visit a program or read a self-study or read something from a program, we look for these. We don't really look so much at, are you compliant? We're looking for these items. So these are the ones, and these are in the order of importance, more or less, to the research. That the number one was an emphasis on quality and safety, emphasis on critical thinking, faculty to role model professional behaviors. And I can't stress that enough, because we get complaints too that are called in for education. And a lot of them are poor, sad students who weren't treated nicely. You know how students are. And so I tell them, we don't have any rules about being nice. Sorry. But a lot of it is just the way they relate to each other. Clinicals with actual patients, big. And this is one thing with Operation Nightingale, with apologies to Florence, that when they don't have those hands-on clinicals, they're really not putting into practice what they are learning in the classroom. And that's where the real learning occurs. I have a handout for you. You don't need to try to write all these down. I have a better handout than this. Process for remediation, clinically competent faculty. This is another issue, that faculty get so involved in teaching that they get away from practice. I didn't want to give this out too early so you'd start reading it. Anyway, we go to programs, and usually at the last of the meeting, when we're meeting with the administrator, who is really all ears, and say, well, let me tell you, I want to tell you what quality indicators we found here. And I go over them and they are so pleased that there are things that they can measure. But I said, there are others you might want to set as goals and hear about these. And so they're extremely interested in that. There's more. Consistent NCLEX pass rates is an indicator of quality, but it is a lagging indicator. That's, you already are having trouble when your pass rate comes up low, then there's already something going on. So that's not the number one thing. Variety of clinical experiences, national nursing accreditation, that does come out that if programs do take that extra step and they get national nursing accreditation, they've raised their standards a little bit. Also, we found out some red flags. And when I presented this at one meeting, I actually took a red flag and waved it. So I forgot to bring it. I was going to bring it, but a lack of consistent prepared clinical faculty. So the clinical faculty, it's seen as a red flag that they're just not there with the students. Limited clinical experiences. So two of them right there about clinical. Poor leadership in the nursing program. I find, and I've been at the board now for 22 years. I was going to be there 2 years, but I lost count. I found that where there is a change in the director of the program frequently, like 8 in 5 years, there's a problem. This is not going to bode well. So good leadership. We look at complaints. That's a red flag. And when we get a complaint from anybody, we always call the director and say, I apologize, but I need to tell you, we've gotten a complaint about your program, and I just want you to know what people are saying. And they're very appreciative, and they give us a response. Pattern of program administrator attrition, that's that leader leaving. Health facilities unwilling to provide clinical, and pattern of student attrition. So those are all red flags. Another red flag is the curriculum is based on teaching to the NCLEX. And this is really, really common. Over-reliance on simulation to replace clinical. And I wrote these other program outcomes. You can look at any of these and tell something about a program, but it's not going to tell you about the quality. That's a different story. Okay, we get this question a lot. Well, how many clinical hours do we need? And we don't have a number in our rules. We kind of resist doing that. It just makes it so you're meeting hours and you're done. So, but we do collect data every year with Hamlauer's help in looking at the clinical hours that programs do. And we have found, if I can find my sheet of paper, that between the RN programs usually do between 400 and 600 hands-on hours, while the VN programs do about 300 to 500 hands-on hours. Now, some are really diligent and they may do 800 or 1,000, but we're trying to find the point that we can say it's probably in this range. If you're not doing that hands-on practice, you probably don't have enough. I found that approximately 84 programs of the RN programs reported over 500 hands-on hours. Another 25 reported between 400 and 500. And 83% of RN programs reported over 400 hours. So if they don't have that, they probably are not doing enough. And then I could give you numbers for the VN. 85% of VN programs report over 300 hours. That's a 1-year program, where an RN program is usually 2 years. So I think, what other overall, I would say just a word about rural Texas. Rural Texas is really a tough place to have enough nurses. If you think Austin is having trouble, the rural areas really. So we really support programs getting started in rural Texas. And one program in the Panhandle, I've never been to the Panhandle, but I know a lot about it, connected up with a number of hospitals in small rural cities. And they made it so that they could broadcast their nursing program to those hospitals, and employers there could go through nursing and become a nurse and do their clinicals in that area. And that's been so successful. That director told me that they got a national award for the most innovative nursing practice in rural communities. And that was phenomenal. So they had written to ask me if they could move on to another city, Canadian. And I mistakenly thought they wanted to move into Canada. And I wrote them this long explanation. Then I realized my error. So anyway, if you have questions about anything else, I'd be happy to answer them. We do have an education newsletter. It's on our website. We print it out about twice a year. We don't print it out. We give it out online, but I would welcome you to go and look at it. These are things that during a quarter, we think, oh, we need to put that in the newsletter. We need to write a newsletter or article about that. And then we end up putting it in our newsletter.
Thank you so much, Janice. I recently had the opportunity to go to Austin Community College, the Highland Mall campus, and to see their simulation program. And I had no idea. For any of the task force members who have not seen it or seen something like it, I'm happy to work with ACC and get something like that set up, or any other facility. But it's amazing the way that they have the dummy and then the microphone and the person in the other room pretending to be the patient, and really creating a patient experience for that learning environment. When you said simulation, it's really understating the quality of that experience. I was really impressed with
It needs to be quality
with what they
trained
did.
faculty.
Excellent. Well, thank you. I think this is really great information, particularly for work groups 2 and 3 to work from. And so we look forward to working with you more.
Thank you.
Any questions from anybody online? Yes, Jamie, go ahead.
I'm going to add to my data questions. I'm interested when she brought up, I guess, the sort of that correlation of the clinical experience to that quality outcome or what's happening. And I'm curious to what extent clinical hours required in curriculum, or if there's some way to know by nursing program the amount of patient clinical experience hours that are happening versus that simulation.
Those hours that I gave to you come from our data report that we do every fall, and we'll be collecting that data again in the fall. But that kind of gives you a range of where we see the averages in numbers of hours. I don't know if that answers your question or not.
I'm kind of interested by program, if it's, and then also what, if there's any route for, if I guess a solution for us to consider is the amount of requirements for clinical experience.
I would
if
say
that's something.
Well, NCSBN also collects national data, and what they have found is across the country, BSN 610 hands-on hours, ADN 445, and VN 406, which is not a whole lot different from what we find in our state. But if we ever needed to commit to a number, I would think we would want to use what we're seeing used successfully. One of the reasons we don't have, at one time when I came to work at the board, we had a number set for VN students, and it was 840 hours, which is a lot for a one-year program. But one of the problems we had is when nurses from other states wanted to endorse into our state, because our law says they need equivalent education, they did not have those numbers of hours and they couldn't endorse in. So when you tie down to a definite number, you start having issues you didn't expect to have.
Jamie, anything else?
No, that's
Dr.
all.
Okay.
Thank you.
Go ahead, Dr. Cerise. You're on mute still.
Okay, that was a great presentation. Thank you so much. Several times the issue of things, competition for clinical space, clinical experience, the need for qualified faculty, those things seem to be just persistent themes that I've heard for many years now as well. I wonder a couple of things. One, do we have any way to quantify what that actual need is, if we're gonna sort of project what the demand is? And then quantify, we need X more amount of time of clinical experiences to meet. And then from the clinical faculty, I know you've used an example of having faculty work part-time in the hospital and teach. Kind of in the medical model, that's all that the clinical faculty do. They're all practicing, and we don't have those same shortages on the medical side. And I'm wondering if or is there a need to rethink that model and to rely on clinical people, practicing people, to form more of the backbone there? Can you comment on those things?
Well, I think nursing faculty do many, many things other than just teach and do clinical, because they're responsible for curriculum changes, all the things that go just with normal education. I like the model where you're working and teaching, and that's what I chose to do early on. And students seem to appreciate that. They know when their faculty know their skill. And I think even to have part-time, that would probably work well, because the practicing nurse might not experience so much burnout from being in the clinical setting all the time. So maybe that's really a good model to think about. When you have faculty who are only clinical and faculty who only teach in the classroom, they don't really know that other side. It's good to have a mix, and that's just my personal opinion. When I worked nights at St. Louis Children's Hospital on infectious diseases, so I never get sick anymore. And I would invite my students. I would be happy if one of you want to come and follow me any night. This is nights, and work with me. And they did. I never had a night I didn't have a student with me. I was talking constantly, but it was a great experience. And a lot of those students ended up working there because they enjoyed that so much. But that's a hard thing to sell, to get people to, well, first of all, to work nights, but.
Dr. Cerise, you're definitely going to want to attend a work group 3 and work with work group 3, because that is where we're really going to be focusing in on the clinical practice and the faculty and how those experiences happen. So this is a great foundation you've laid here, Janice, for those discussions. Really appreciate it.
Thank you.
Dr. Rice Spearman, sorry. Oh.
Yes, thank you for recognizing. I'm really encouraged with what I'm hearing, but I also would like to challenge the task force on how do we leverage technology and innovation so that we're trying to do something different. I feel like sometimes in all of the healthcare fields, we continue to do the same thing and expect a different result. And so I really am hopeful that this task force is really going to push itself and think outside the bounds of how we leverage technology to address some of these two important issues around faculty development and clinical rotations.
Thank you very much. Anybody else? Okay, we are going to move on to our next speaker with the Texas Nursing Association, and that's Jack Frazee. Very excited.
Hello. Thank you, Madam Chair and members of the task force, for having me to speak with you all. My name is Jack Frazee. I'm the Director of Government Affairs and General Counsel for the Texas Nurses Association. I wanted to kind of zoom out and give y'all sort of a sense of what Texas has been doing since the pandemic and some of the policy changes that have happened, because there have been a very significant number of policy changes in a relatively short period of time that I don't think have been covered yet. And it's going to be helpful to give y'all context for what's happened and where we're going and kind of where we are in the process. In the handout that I gave you, so y'all don't have to take notes on everything that I rattle off here, it's going to give you sort of a list of programs that have changed over time and sort of what's happening with those. For the folks that are joining virtually, I will send a copy of this to the clerk so that can get passed out. So the really high note thing that I want to impress upon the task force right now is that our shortage is mainly felt in the RN licensure track. So within nursing, you have LVNs, RNs, and then APRNs, folks that are graduate trained. And the RN licensure space is where the need is greatest. We have about a shortage of 45,000 RNs in Texas. And that is much more pronounced than what you see in the other licensure tracks. So a lot of what the legislature did over the 88th legislative session was try to figure out how do we address that specific shortage. And most of that was done through Senate Bill 25. So that was a priority bill of the Lieutenant Governor. It was taken up by Senator Kolkhorst, and she really kind of led the charge on the research and development of that bill. So we are in a very good spot as a state in terms of policy tools that we have in our tool belt because of that legislation and the initiative of Senate leadership. So I want to just kind of go through and talk about what the bill did and give you all a sense of where we are in implementation and then what wasn't taken care of in that legislation and sort of the opportunities that gives us moving forward. Within that bill, there is a long list of programs that were addressed. Several of these things already existed in statute, but they needed to be modernized because, as we've already heard, some of our sort of old delivery models had been changing. That same thing applies in education. So one thing that is a brand new program, this was really championed by the Lieutenant Governor, is the Nursing Scholarship Program. That provides scholarships to students who otherwise couldn't get into our nursing schools because they can't afford it. So that's going to help us tap into a lot of folks that want to go to nursing school but otherwise couldn't have. There's about 12.5 million that's going to be distributed over the course of the next year, and that's brand new. So those funds have not been dispersed yet. They are about to go out. The Higher Education Coordinating Board is in the process of finalizing rules for that. Similarly, we have something that is also brand new called the Nursing Loan Repayment Program. This is going to provide really a retention mechanism for keeping nurses in Texas. It's another 12.5 million that's going to be going out over the next year. And that money is basically meant to tell nurses, hey, if you're working here in Texas in some nursing profession, we want to keep you here. We're going to help pay off your student loans as long as you keep working as a nurse in Texas. Then there's something that is specifically targeted to faculty. The two major bottlenecks that we hear about in the nursing education pipeline are insufficient faculty and insufficient clinical resources. So for faculty, the problem that we have from a policy standpoint is that you can make more money in clinical practice than you can working as faculty. That creates an inherent economic disincentive to work as faculty. So the way that we are addressing that in Texas is through this loan repayment program. If you're working as faculty, you can get your loans paid off. It used to be that you could get $7,000 per year that you participated for up to 5 years. So 35 grand, not that bad. But that really had not kept pace with inflation or the growth in the cost of education. So what Senate Bill 25 did was it removed that statutory cap and now allows the Higher Education Coordinating Board to give out as much as they can based on funding that's provided by the legislature and the number of applicants that they have. It also used to be limited to full-time faculty. Now that includes part-time faculty. When this program was originally passed, we primarily just had full-time faculty. Now we're at about a 50-50 split. So 50% of our faculty tends to be full-time, about 50% tends to be part-time. So this just kind of brings it up to date and makes sure that eligibility is mapped onto what's really happening in the field. Then we have something called the Nursing Innovation Grant Program. This program is really directing funds towards innovative ways of expanding the pipeline. A lot of that money ends up going towards simulation training. So over the past several grant cycles, we've seen funding go to schools so they can set up sim labs. I think that is especially going to be important going forward because the Board of Nursing changed some of their rules around that and allow for about 50% of your clinical training to be done through simulation. It used to be, if I remember correctly, at 70-30 split with 30% being through simulation. So that is going to allow us to free up some of the clinical space that we have. As you all know, there's a lot of competition for those clinical slots, whether you're nurses or any other health profession. And so anytime that we can put some resources towards simulation training, that's going to help free up space there. That money primarily comes from the Texas Tobacco Lawsuit Settlement Fund, but in this last session, there was a rider that added another 6 million to that program. Then the last thing that has been around for a while, but had some significant changes through a rider in the General Appropriations Act, is something called the Nursing Shortage Reduction Program. This is a very flexible program. It basically allows nursing schools to put funds toward whatever they see the needs are in terms of expanding the pipeline and producing more graduates. The change that happened in the rider is that it set out 3 different tiers for how that funding can be awarded. There's sort of different criteria and different buckets of money that go into that. Some of it is about growing the number of graduates that you put out. Another really rewards you for having just a large number of graduates in general so that you can be rewarded for that and then invest those funds in continuing to grow. And then there's one that's focused on the production of faculty. So those are the things that were funded in SB 25 that exist right now, and the funds are going to be going out over the next year. The rulemaking process has taken about a year to get in place. All of this money is coming out in this biennium. So those are going to be extremely helpful resources to the state. It's going to position Texas better than most other states. When I travel around and talk with other folks within the American Nurses Association, they're all very jealous of what Texas is doing because a lot of states have not taken these kinds of thoughtful steps toward addressing their pipeline issues. There are some other things that were added into SB 25 that didn't get funded, and these are going to be really significant tools going forward for Texas. The reason that they did not get funding is that there was an amendment on the House side that added these programs as the budget was being finalized in the Senate. So we just didn't really have the time to sync up on those things. But it's going to work out pretty well because a lot of the funding in SB 25 and the General Appropriations Act look at the front end of the pipeline, addressing didactic training and kind of greasing the wheels to get us into clinicals. But all of these other programs are specifically about clinicals. So there's one that's specifically looking at clinical sites and nurse preceptors. Nurse preceptors help clinical faculty extend their ability to train nursing students. Then we have another program called the Clinical Site Innovation and Coordination Program. This is really meant to help coordinate clinicals within any kind of geographic region and invest in those clinical sites. Then we have one that's called the Nursing Faculty Grant Program. So this helps invest in nursing faculty that are doing clinical training. And then a nursing faculty grant program focused on clinical training of that faculty. So they get more and more skills in how to continue clinical training. So a lot of new programs. I know I threw out just a word salad there on programs, but I just wanted you all to be aware of the fact that those exist, that the funds have not fully been dispersed, and that we have new programs that can be funded in the next session that will be helpful, especially on the clinical side. The other thing that I want to pick up on that Dr. Zerwas mentioned is these programs that we've had historically are very effective when they're funded adequately. So if you go back and look at the history of these programs, you'll see there's been fluctuation in their funding. For example, the Nursing Shortage Reduction Program got the most funding in the 2010 biennium. And you can see in the data, the number of graduates that we put out, there's a significant increase that maps along with that funding. As the legislature reduces funding for those programs, you see the growth drop as well. So as long as these programs get funded, they do work and they have been modernized just recently. So things are changing and I expect to see a lot of benefits from SB 25 and the associated funding. It's also good to know that this last session represented the largest investment in nursing education in state history. So that funding is going to be rolling out soon. And obviously there's going to be continued investments that need to be made to keep up with the need that we have because it's such a significant need. There are a ton of trends that are driving the shortage that we have. Part of it is the population influx, the graying population that we have here in Texas. But then also there's a lot of practice challenges that I'm sure you'll hear about from folks as you're doing this task force. One thing that we have already heard touched on is there's a lot of turnover with new grads. And part of that is that, you know, if you have a shortage of 45,000 nurses, that means that the folks who are working are going to be spread thin. That makes burnout much more likely. It's also overwhelming if you're a brand new nurse and you suddenly have a huge patient load and not enough people there to support you or train you. So what we are seeing, unfortunately, is a lot of turnover in folks who are just out of nursing school. Some of those people are leaving the profession entirely, just saying, hey, this is more intense than what I thought I was signing up for. Other people kind of take a break and come back to it or find different roles. So one thing that health systems can do is really focus on supporting those new grads and making sure that we're retaining those folks. Outside of just education funding in the pipeline, there's a handful of things that I think we can be looking at as a state. One is we have a staffing model here in Texas that is different from other states. It's really meant to try and draw from the expertise of nurses in practice. So if you look at nurse staffing and kind of the different policy models, depending on the state, we are one very typical example. And then you have sort of contrasting examples like like California. So as an example, in California, they have top-down mandated nurse-to-patient ratios that everybody has to follow. It's very heavy-handed and enforced by the state. In Texas, we have a much more flexible model. It's meant to drive staffing committees that are made up of nurses in Texas. They basically provide policies for the hospital on how to staff their units and advise the board on good staffing policies. One thing that we have learned in going around and talking with nurses in Texas is that all of the best practices around the staffing committees and staffing policies really kind of fell apart over the course of the pandemic. And that's because there was a lot of crisis staffing. We had a public health emergency declaration that went on for 3 years. And when that declaration is in effect, it triggers an exception to our prohibition on mandatory overtime. So you see a lot of those practices around making sure that we have adequate staffing falling apart. And so that's something that I think health agencies should take note of and just be careful to monitor compliance with that law. But also health systems can be taking a proactive role in making sure that those committees are working as they're supposed to and that staffing is being done in a way that's actually sustainable. Because if we have nurses that have too many patients, then that contributes to burnout and they quit. So that's something that I just want to flag for you all as well. Picking up on some questions that I heard from members, we don't have an exact number of how many applicants that we're getting that get turned away, but we do have qualified applications not offered admission. There's a level of duplication in that data, so I just want to flag that for everybody. But we have seen growth in the number of qualified applications that are not being offered admission recently. The most recent reported numbers, it was slightly over 15,000 applications that were not offered admission. So even assuming some duplication, that's thousands of people who could be going into our nursing programs that just didn't get in. My understanding is that primarily it's because we have a lack of faculty and a lack of clinical space. And so if we can address those issues, then we can bring in more students. Let's see, I want to make sure I touch on some other things I took notes on. I think that's everything unless there are other questions.
Jack, the items that didn't get funded in Senate Bill 25, what was the cost estimate for those?
So that really is going to depend on the appetite of the legislature. I know that the Teaching Hospitals of Texas had tried to do an estimate for those programs and gave an estimate of about 100 million. I think that's ambitious. Obviously, you can be more ambitious if you want to, but it just depends on what the budget allows. There's such significant need that I think the state's going to have a hard time overspending right now. But again, there's competing priorities, and so that's a judgment call for the legislature.
Great. Thank you for that background. Anyone on Zoom have any questions? Dr. Ward, you could go ahead.
I have not a question, but a comment. Thank you for your update. And I do full-heartedly agree with you that Senate Bill 476, which was around the staffing committees, I think is something that organizations must pay attention to. Go back, reassess, evaluate how effective their organizations are aligning to that. I do think it's a component of reducing burnout for sure, because if we can stop the hemorrhage of them leaving, then we can then begin to build up the infrastructure for nursing. I do think funding helps organizations to be able to do that, though. Staffing ratios is certainly not something that I think Texas has been a proponent for, because acuity of patients fluctuate. And we don't want to put our nurses in the situation of having to determine how they're going to care for patients based on the acuity of the patients. But I do agree with you that Senate Bill 476 is critical to the support of nursing burnout, to alleviate it.
Just to add to that, we have asked our members, what is your preference? Are you looking for something like some kind of nurse to patient ratio? And that is not what we hear from them. They like the committee model. It is incredibly complex to staff as conditions are changing and as you have different acuity. We have really high acuity patients right now. So it's good to use the expertise of your nurses to figure out what are the needs right now, and then how do we address that with the resources that we have.
Thank you for your comments, and I want to just pile on a little bit what Dr. Ward said, that if we don't address the burnout issue, and the burnout issue I think has to be an institutional responsibility primarily. We see it among the physician cohort also, and have large numbers of groups working on this kind of issue and stuff. But I think between our population growth, burnout, as much as I have ambitions for Senate Bill 25, and I do, I think it's great. Representative Colcourse worked on this a lot in our early days and has continued to make it a priority. I think we'll just sort of be keeping up, and by keeping up means we're always in a deficit and stuff. And so I think if we don't address that burnout issue, we're going to lose the mileage out of a lot of our talent, frankly, and stuff. And so I know at UT we have groups working on this, which is why I say it kind of falls down to an institutional level to make sure you're putting in the programs to best deal with that and so forth. But it's a constant loss of great talent out there that can't keep in, makes it hard for us to keep up with the pipeline of talent when we see the population growing like it's growing. The other thing I'll mention is, we've always seen great ambitions for technology and how that will, improve the work environment for nursing care as well as physicians care and stuff. I think right now we're still in a mode though where it's actually creating more work than it's actually relieving the work burden that we have. I have great ambitions that will turn around, I think, and there's some amazing technology that's coming on board in the healthcare environment, directly patient facing. But it's kind of a work enhancing technology. And by that, I mean workload as opposed to work relief. But again, I think that's probably something that as we get better and better at this and incorporating it into the patient facing environment, that it'll actually become a work relief to some degree. So thank you.
I agree. I'll just add that we hear from our members, the documentation burden is really significant, and that's part of why they're so stressed out. Obviously, that has more to do with CMS than anything the state can deal with, but if the feds are listening, please try and address that.
Anybody else? Okay. Thanks so much, Jack.
Thank you.
Appreciate that. Already great feedback to use for the workshops for the advisory committees. Now I'm going to really do a deep dive in the data. So Pam Lauer from the Department of State Health Services, Health Professions Work. She'll get through her title, and I'm real excited about this presentation. So thanks so much for being here with us today.
Well, thank you for having me. I'm Pam Lauer, and I'm with the Texas Center for Nursing Workforce Studies, and I also oversee the Health Professions Resource Center at the Department of State Health Services. Let's see. So our Workforce Center is focused on studying the supply and demand for nurses in Texas, and today I'm going to share some data with you, but this is to highlight that we have a lot more data than what I'm sharing with you today. So we collaborate with the Board of Nursing on the annual nursing education survey of all the vocational, professional, and graduate level nursing education programs in the state. We look at supply and demand trends through licensure data that's collected by the Board of Nursing. We also work with a contractor on projections, and the projections I'm going to share with you today are the same ones that are used by HRSA, the same model, but we put Texas level data into it, so it's much more accurate for us in our state. We survey employers of nurses, including hospitals, nursing facilities, home health and hospice agencies, and governmental public health agencies. We also have some initiatives focused on workplace violence. So we survey nurses about their workplace violence experience, and we also implement the Workplace Violence Against Nurses Prevention Grant Program. Okay, so some of these slides have a lot of information in them. This one shows the number of practicing nurses in Texas. Now, Ms. Thomas earlier shared some numbers related to licensees. The numbers that I'm going to talk about are focused on nurses who are licensed in Texas, practicing in a nursing position on a full-time or part-time basis, and practicing in a Texas county. So it will exclude any Texas licensed nurses that may be working out of state. As you can see here, there are more than 327,000 nurses practicing in Texas across licensure levels. The number of RNs, and ignoring 2020. So you can see in 2020, there's a dip for all of those nurses related to the ones that were practicing in nursing. But the overall trend has been an increase across all nurse types. So the number of RNs has steadily increased over the last decade. It increased by more than 21%, or more than 41,000 RNs during that time. The number of VNs has been on a decline since 2019, and the number of APRNs has more than doubled over the last decade. This slide shows the trends of nurses per 100,000 population. So that top line that's in orange represents registered nurses, and you can see that overall, the trend shows that the ratio increased between 2014 and 2018. Then again, we see that dip towards 2020, and then it has increased again from 2020 to 2023, but not at a very fast rate and not probably at the same rate as the population. So in 2023, we still have a ratio that is lower than it was in 2018. The VN supply ratio has been on a steady decline over the last decade, while again, the APRN supply ratio has nearly doubled. This table includes the nurse ratios by region. For LVNs, RNs, and APRNs, the numbers that are highlighted in green represent the regions with the highest ratio, and those that are highlighted in red represent the regions with the lowest ratio. So you can see East Texas has the highest ratio of LVNs, and the Gulf Coast has the lowest ratio in the state of LVNs. For RNs, the Panhandle has the highest ratio, and the Rio Grande Valley has the lowest ratio. And then when it comes to APRNs, again, the Panhandle has the highest ratio, and the Rio Grande Valley has the lowest ratio. This slide shows some VN demographics. The median age of VNs in 2023 is 45, 88% are female, a quarter report their practice specialty as geriatrics, and more than half are from a racial or ethnic minority group. The RN demographics. The median age for RNs in 2023 is 44, 87% are female, nearly 2/3 are employed by hospitals, and more than 63% have a BSN or higher, and nearly half are from a racial or ethnic minority group. And finally, for APRNs, the median age is 45, 83% are female, 85% are nurse practitioners, about 47% are of a racial or ethnic minority. Now, I did include any slides related to the trends, but in general, the nursing workforce is a little bit younger than it was a decade ago by median age. It is more racially and ethnically diverse, and it is much more educated in 2023 than it was 10 years ago. Okay, this next section is on admission trends. So this relates to the questions that were asked for VN programs, and I'm going to read through this because there's a lot of lines. So the figure includes several variables. The blue line at the top, the dark blue line of the figure, represents qualified applications. And like Mr. Frazee said, qualified applications include duplicates. We're not talking about people or applicants, but the number of applications submitted across all programs in Texas. The orange line represents those offered admission by the program. The gray line represents seats for new students. The yellow line represents those students who were admitted and then registered and enrolled. And the lighter blue line on the bottom represents those qualified applications that were not offered admission. The overall takeaway from this figure is that in VN programs, applications and admission trends you can see have declined over time. The next slide shows VN graduation trends, and you can see that that number has been decreasing pretty steadily since 2014. And it declined about 30% over the last decade. Now here is the same figure for the RN admission trends. And the colors all apply to the same items. So data from 130 programs in the 2023 NEPIS reported just over 25,000 seats available for new students. And that's the gray line. And that represents about almost a 10% increase from the previous year. Those same programs reported over 39,000 qualified applications, which represents about a 4% increase from 2022. Again, that's the dark blue line at the top. We also want to point out, again, I say this multiple times every time I present this, that we're talking about applications and not people, and we don't know what the duplication rate is across programs. So looking at those who are offered admission, 26,205 applications were offered admission. That is a 6.1% increase from the previous year. However, almost 14,000 applications were not offered admission in 2023. So looking at the last line, which is the yellow one, newly registered enrolled students, there were over 20,000 newly registered students in 2023, but that only represented less than a 1% increase from the previous year. This shows the RN graduation trends. So you can see that there's been steady increase in the number of students that are graduating from nursing education programs in the state. That was 130 programs again in 2023 that reported almost 15,000 graduates. And you've heard this a few times today, but I'll say it again. We ask programs who do not admit all of their qualified applications for the reasons that they did not admit them. And we also ask all programs what barriers they face in increasing the number of graduates from their programs. The answers are the same. It's lack of clinical space and lack of faculty positions and applicants. And that has been consistent since we've asked these questions in the NEPIS for the last 12 or 13 years. Okay, so I have just a few slides on employer trends. So like I mentioned, we survey hospitals, nursing facilities, home health and hospice agencies, and governmental public health agencies. And we ask them several questions about their number of employees they have, the vacancies, the turnover. We ask them how many additional staff they expect or need in the next year. We also ask them what types of attributes they're looking for in their applicants. We ask them about their recruitment and retention strategies, and then a number of other things. This data is most recent from 2022. We are currently collecting that data, so we expect to have updated information late in the fall. So you can see here the nurse vacancy rate trends in hospitals, nursing facilities, and home health agencies for RNs, LVNs, and nurse aides. And I think the main takeaway here is that you can see from the 2019 survey to the 2022 survey, those vacancy rates increased for all nurse types across all settings. I will say that these surveys go out to all of these facilities, but it is not a required survey, so our response rates vary across settings and from year to year. The other slide from this data has to do with turnover. In hospitals, turnover increased for registered nurses and nurse aides. In nursing facilities, turnover increased for RNs, LVNs, and medication aides. And in the home health setting, LVN turnover increased while RN turnover decreased. Okay, the next few slides have to do with supply and demand projections. A few things, I already mentioned that we use the same projection model that is used by HRSA, but we adapt the model and put in Texas specific data into it. So HRSA's numbers might include like nurse supply estimates based on data from the American Community Survey or other sample surveys, while all our data includes numbers that come directly from licensure. So they're very accurate in that regard. The main takeaways from our most recent projections, which were published in 2022, were that by 2036, projected shortage of LVNs and RNs will persist. The shortage of LVNs is projected in North Texas, Central Texas, and the Gulf Coast. And the shortage of RNs is projected in all regions except for the Panhandle. And that is pretty consistent with our previous projections. So demand for nurses in nursing homes, residential care, and home health settings is projected to grow at the fastest rates. I will get into the specifics of them, but a few other considerations about these projections is that these numbers represent full-time equivalents, not people. And demand projections are based on changing demographics, while healthcare use and delivery patterns remain unchanged. So it's like a status quo scenario. And then the demand projections are based on national healthcare utilization patterns. So the demand model is projecting the need for nursing services. It is not labor market demand. So we're not talking about the demand for jobs necessarily, but it's based on the utilization of nursing services by the population. And the other thing that I always like to mention is, again, when we're talking about these projections, they're a tool, and these numbers represent FTEs and people. They're not necessarily representing the level of specialty or experience or anything like that that employers might need to fill their positions. Okay, so these are the LVN projections. There's a projected surplus of LVNs that is projected to become a deficit in about 2033. Now, I will say the projections, the baseline year is based on the previous 3 years of licensure data that we have. So the 2022 baseline number is based on data from 2019 to 2021 or 2022. And if we look at the data that we have, it probably doesn't take fully into account the decrease that we're seeing in LVNs in actuality. So these projections, the next time that we do them, might show that that line to be a little bit steeper sooner. So while demand is projected to increase, the supply of LVNs is projected to only slightly decrease. And you can see that it leads to a deficit of almost 4,000 LVN FTEs by 2036. By region, most of the regions in the state are not projected to have a shortage in 2036, but North Texas, Central Texas, and the Gulf Coast region are the ones that are projected specifically to be in shortage. This slide shows LVN demand by setting. The dark blue bars represent the projected demand in 2022, and the lighter blue bars represent projected demand in 2036. Demand for LVNs is projected to increase in all settings, but you can see that nursing homes are where the demand for LVNs will grow the most, both in absolute numbers and by percent change. Okay, updated projections for our registered nurses are consistent with our previous projections. The deficit of RN FTEs is projected to increase from about 45,000 to over 56,000 FTEs by 2036. And yeah, so that is very consistent with all the previous projections that we had that were showing about 60,000 FTE deficit. Okay. Every region except for the Panhandle is projected to have a shortage by 2036. And the darker the region, the higher the deficit. That there isn't a projected deficit in the Panhandle is also consistent with our previous models. And it's kind of, I don't want to say that it's a fluke in the projections, but the Panhandle is unique in that their population is very low and they have a very large health science center with a lot of nurses and a lot of production of nurses. So that's why it looks that way. But this is a great example of why these projections need to be used in conjunction with other data that we have. So while we show that there's a projected shortage for RNs, we know from our staffing studies that the hospitals in the Panhandle continue to have vacancy rates. And in our last study, I believe the vacancy rate for RNs in the Panhandle was about 12%. Okay, this figure shows the demand by setting for RNs in 22 and 2036. And as you might expect, demand for the greatest demand is for RNs in hospitals. They employ 2/3 of nurses in the state, but the greatest growth rate in demand is in nursing homes for RNs as well. Okay, so that's what I have on nurses. I was also asked to share just a few things about some allied health providers. So I've got a slide on nurse aides, and this shows the ratios of nurse aides per 100,000 population. Both the absolute number and the number of providers per population for CNAs has been on the decline for the last decade. So you're looking at the supply ratios. It was about 458 nurse aides per 100,000 population, and it's down to 264.8 in 2023. This figure shows the number per 100,000 population of medication aides. In the blue, surgical assistants are on the orange line and paramedics in the gray line. And while there has been an overall decrease in medication aides over the last decade, the supply ratio has improved from 21 to 2023. The ratio of paramedics to population has increased over the past decade, and the rate of surgical assistants has also increased overall, though at a much slower rate. I want to note that for paramedics, the legislature invested $21.7 million during the 87th session to address dwindling numbers of EMS personnel working on EMS vehicles. And education and public awareness campaigns were intended to get people into training programs or recruit personnel back from brick and mortar healthcare settings, where EMS providers were commonly switching over to work during the pandemic. So future conversations about the nursing pipeline and attracting allied health to the nursing profession may want to keep those sorts of things in mind. Okay, and this table includes the provider ratios by region for all 4 types. The numbers, again, highlighted in green for this region are the highest ratio. And for nurse aides, there's a mistake because I highlighted Panhandle, but it's actually East Texas that has the highest ratio. And the lowest ratio for nurse aides is in Central Texas. For medication aides, the highest rate is in East Texas and the lowest is in the Rio Grande Valley. For surgical assistants, the highest is in the Gulf Coast and the lowest is in East Texas. And then for paramedics, the highest is in West Texas and the lowest is in East Texas. Okay, so we'll have updated hospital nurse staffing study results hopefully by September, and then the ones for our other settings hopefully by December. We get licensure data typically in September of each year, so we hope to have updated numbers for 2024 by late December, early January. And then, of course, like I mentioned, we have a lot of other data, nursing education data, things that are accessible, and we're happy to share any of that as well.
Thank you so much, Pam. Just on that allied health, continuing, do you all track things like phlebotomists or other kinds of technician positions and roles in healthcare, just for perspective?
There are about 40 different ones that we track.
Okay. Okay, good. We'll circle back around and talk about those a little bit more when we have a chance. Thank you. Okay. Any questions? Oh, yeah, we got some. So Dr. Valerio, let's start with you.
Thank you, Madam Chair. My question is addressed to Pam, and also I want to mention this item that we need to consider as a committee. You may have mentioned this, Pam, but I may have missed it. There has been a noticeable rise in the number of APRNs, but I am interested in the data regarding NPs that have obtained advanced degree, but they are not practicing. So by virtue of their degree, they already meet the minimum requirement to become a faculty. Additionally, if there is, I know I have encountered an article in the Rio Grande Valley region that there's a surplus of NPs. As a committee, how can we attract these individuals to the academia, particularly in light of the significant salary disparities between clinicians or clinical NPs and academic position, as noted by Mr. Jack Fraze?
So Pam, do you track data about people who have the qualifications but are not practicing? Is that a way, is there a way to track that data?
So we know all of the nurses that are licensed as NPs. We know how many graduate, but we wouldn't be able to track how many graduate from like a master's program and then don't get a license. And then we do have a listing of all faculty in the state. So we could feasibly look at, you know, how many are APRNs and then how many additional APRNs are not practicing as faculty.
Okay.
Thank you.
What else we got? Okay. Any other questions up here? Thank you very much. We will continue working with you and we appreciate all your help with this.
Thank you.
Okay, next we're going to hear from the Texas Workforce Commission, Marian Vega, regarding allied health workforce data. Great. Thank you so much.
Okay, and I think it's on. Hi, everyone. Mariana Vega. I am the Labor Market Information Director at the Texas Workforce Commission. And thank you so much for inviting me to speak at this meeting. We did meet with the co-board and DSHS prior to this meeting to discuss some occupations that would be the focus of the report. And that would be nursing occupations and any occupations that could possibly lead lead to nursing. So we did, for the data that we pulled, we did focus on those 12 occupations that are listed on the handout. The 6-digit number right next to the occupation title is a 6-digit standard occupation classification code. It is used by most federal statistical agencies to classify workers into jobs, job categories. And this is how we collect, calculate, and disseminate our data. So all of those occupations on that list are highly concentrated in the healthcare and social assistance industry sector. That sector is mainly comprised of establishments that do provide healthcare and social assistance for individuals. Right below the list of occupations, we did provide some industry projection data to show that at this level, that 2-digit industry is the #1 industry of employment in Texas. With over 1.6 million jobs. It does make up about 15% of total employment in Texas. It is expected to grow by about over 23% by 2030, adding over 360,000 jobs in Texas. That growth is faster than the 18.3% expected growth for total all occupations in Texas. It is expected to add more jobs than any other industry at the 2-digit level in Texas. So we just wanted to show the importance of that industry. Following on page 2 is the data that we do have available for each of the occupations listed. We use 2023 occupation employment and wages from our occupational employment and wage statistics program, as well as long-term projections data. If you look at the chart, here's where we run into some nuances that do affect the data. The data come from 2 different programs because of differences in collections and the purpose of why that data is collected within each program. Combining the data from different programs can provide some challenges. So if you look at the chart, in this case, the programs are under 2 different SOC taxonomies from different years. So if you look at the chart, there is some missing data for some occupations denoted by the asterisks. A lot of times occupations are condensed or expanded considering the taxonomy. So for example, if you go down to row number 5, emergency medical technicians and paramedics, that was combined for the projections program. So we do have projections data for that occupation. However, the OEWS program, where we get employment and wage, emergency medical technicians and paramedics are 2 separate occupations. It's a lot easier for us to produce special projections or special wage data for the projections data. However, we can't do it the other way around. We can't provide projections for the wage data. So this is the data that's available. The issue will be resolved, by the way, when our new projections are released in the fall of this year, around September. If you look at the data, all of the demand for all of the listed occupations is considered healthy. All of the occupations are expected to grow by over 14%, with the exception of psychiatric aides. If you look at that employment, it is very small. It's about 1,000 in employment for that occupation. Registered nurses has a projected employment of over 250,000 by 2030. That's an increase of over 17%. Home health care and personal care aides is the largest occupation by employment, and that has a projected growth of over 30%. If you turn to page 3, we do have some supply demand data. This is not an analysis because you would need to consider a lot of other data to really complete a supply demand gap analysis. But we do have data that speaks to the demand that we have for each of those occupations in Texas, as well as some supply of worker data. We do use Help Wanted online job posting data to determine what the immediate demand by occupations is. For supply, we use Work in Texas. Those are potential job seekers. They are job seekers that have created a profile in the state's workforce application system that provides access to job matching services. It is somewhat limited because it's not a one-to-one match. One job seeker can essentially be qualified for more than one occupation. It is based on that user creating a job profile and what their experience and work history looks like. So there is some data limitations. As you can see on the data, you can see registered nurses shows a large gap, meaning there is currently a really large demand for registered nurses. However, our current supply in our Work in Texas registry is limited. So there is a need for registered nurses that we can see. Home health care and personal aides does show that there appears to be an oversupply. But you have to remember this occupation is also a feeder into many other higher paying occupations, nursing occupations, as well as other healthcare occupations. So if we turn the page to page 4, we have additional supply demand data. This is on an annual basis. And here we use annual openings from our long-term projections data from 2020 to 2030, where you can see demand. This demand does include exits. So exits can be from retirements, transfers from one occupation to another, as well as just your organic growth that we typically see year to year. We get annual graduate and enrollment data from the CoBoard, which speaks again to the supply of data. Long-term, our data does show there's a great demand for healthcare personal care aides, nursing assistants, LPNs, LVNs, and phlebotomists. If you look at the data, there does appear to be, let's see. Okay, if you look at home health care and personal care aides. So we don't have graduate level data for that occupation. We get that data from the CoBoard, which is mostly 2- and 4-year institution graduate data. The typical education needed for entry for that particular occupation is the high school diploma. So that is why there is no graduate data. Nursing here shows an oversupply. However, these projections were produced with a base year of 2020, which is, you've heard from other speakers, it was a very challenging year. It was for us too. Our response rates decreased tremendously. We did review the data from Board of Nursing. They have some data on delinquent and inactive licenses, as well as retirements. And we did see an increase in all of those for every year after 2020, so 2021 to 2023. So that can explain, again, some of what seems like a discrepancy in the data. As someone else mentioned before, we always do advise to use different data sources to kind of complete that picture. On the next page, you'll see some career pathway information. Just want to make sure I didn't skip anything. That information does come from Lightcast. We don't produce it ourselves. It's a third-party vendor data. We use their career pathway module, and it shows the occupations considered to be feeder jobs into those pathway jobs. And again, we just focused on those 12 that were on the list. We can certainly produce additional data. We do have a data for over 800 what we call official occupations as determined by the Bureau of Labor Statistics. So we can get additional data if it's needed. Lightcast does use categories to define the type of transition from one job to another. So for this list, the categories are advancement, jobs that pay more, but they're within the same occupation group. Lateral advancement, jobs that pay more but require transition into a new occupation group. And then lateral transition, jobs that pay a comparable salary, but they do require transition into a new occupation group. And they do use SOC codes, standard occupation classification codes, just like us, which are categorized by major, minor, broad, and detailed occupations. And then on page 6 is licensure data that we also collect. This is directly from the directory of licensed occupations that we produce. But I'm sure you probably already have that information, or there's other agencies that can probably provide more detailed information, but we do collect some of that. So we just wanted to let you know that it is available if you need that. So that's pretty much what I have. I did want to say that, obviously healthcare and social assistance has become a very important industry in Texas. As I mentioned, it's the #1 industry of employment in Texas. Part of it is population growth. As mentioned before, Texas has seen population growth year to year for the past 22 years. We've actually ranked #1 as far as the state adding more people to our population since 2010. So that has been, since 2010, about over a 15% growth in our population, which, as you know, with population growth, it increases the needs for services, including healthcare. So that said, that industry has grown since COVID, 8.6% past the pre-COVID level. So since February 2020, that industry has grown by 8.6%. That's an increase of 103,200 jobs. And we do foresee that it will continue to increase, obviously, because of the population growth and need for healthcare services. So that concludes the information I have for you. If you have any questions, I'll be more than happy to answer those.
Thank you very much, Mariana. I do have a couple of questions. Kind of want to talk a little bit about how the Workforce Commission encourages or doesn't encourage or educates the public about high demand jobs, and in particular, obviously these jobs, but kind of in general. I mean, I should probably know this, but is there a workforce plan, or is there a mechanism that the Workforce Commission uses to try to encourage folks to go into certain fields?
Sure. And I could speak from the labor market information perspective, because we do support our boards in that way. They do come up with 4-year board plans where they look at not only jobs that are in demand, but also they come up with what they call a target occupations list, meaning it has to be a high demand job, but they also have to have eligible training providers so they can train the workforce into those occupations. So we do work very closely with our boards to provide that data. Additionally, we produce a lot of resources for students, typically aimed at the high school level. We do have a few resources for elementary and middle school students to help them explore occupations that exist that are in high demand and good paying jobs. Not all are your typical 4-year college degree occupations. There is occupations with a varied degree of education.
Okay, we have a couple of workforce boards here who are coming up next. I'm
Sure.
real happy that we got them to participate. But the primary kind of workforce planning happens at that board level, at the local level.
At
Is
the
that-
board level,
that
I would say.
accurate? Okay, great. Thank you.
There's additional, I would say, initiatives that
Sure.
the agency supports, but at the board level, I would say that's where it starts.
Okay. And lots of good reasons. Texas is a big state, all of those things. Okay. Any other questions from anyone else? Okay, great. Thank you so much.
Thank you.
Uh, Juliet with the Gulf Coast Workforce Board. Hello, I am not going to mispronounce your name. Stepetch. Great. So thank you very much for being here.
Thank you very much. It's such a pleasure to be able to join you here. My name is Juliet Stepetch. I'm the Executive Director of the Gulf Coast Workforce Board. Let me make sure I know how to use this correctly. So just a little bit of background. There are 28 workforce boards situated throughout the state of Texas that work with the Texas Workforce Commission, of course. And each board has its own leadership. In the Gulf Coast area, we have about 48 members of our Gulf Coast Workforce Board at present right now. 51% is represented from private industry, but we also have a combination of individuals from post-secondary, the K through 12 system, community organizations, and also childcare. And so this is an overview of our mission and vision. And so we help employers meet their workforce needs and individuals build careers so both can compete in a global economy. And so we are just blessed to be in the Gulf Coast region. We have the Texas Medical Center, which of course is the largest medical complex in the world, about 10 million patient encounters annually, 120,000 employees, 9,200 beds. And so you see this picture of what the medical center, part of it looked like many years back and to where we are today. There is significant growth in the region. And so we know that the healthcare industry is the largest employer in the Gulf Coast region. And, you know, shortages are not only in nursing, of course, they're in life sciences and new areas of growth, such as stem cell therapy and things along those lines. And so changes that occur in the research and the center of the heart of Houston in the Texas Medical Center will impact the region as well as the state. So earlier you heard from Ms. Vega, who explained that we have a local workforce plan that is developed and placed for 4 years. In that time frame, every 2 years, we look at the different types of high skill, high growth industries that are on that list. And from that list, we work with our training providers in the region who are a part of this eligible training provider list. In that, when a customer comes into a Workforce Solutions office, they are provided career advising and counseling. And if they are eligible, then they can receive a scholarship for upskill training. Now, in order to get that upskill training, the particular area of study should be on that eligible training provider list. And so that's why it's very important for us to curate it, but also at the same time, this list sometimes lags with, you know, industry growth and labor shortages. We want to make sure that we have innovative courses available for our community, but sometimes the labor market information lags. And so we're trying to look at ways in which we can develop a system that's much more forward thinking as well, that can address the needs of the community, you know, 5, 10, 20, 50 years down the road as well. And so we are looking and exploring at different ways of trying to meet with industry partners as well as persons in the post-secondary level, so that we can talk about ways that we can modify and keep this more up to date, so that persons, when they come in, they can be counseled into appropriate areas of study that will meet the needs of employers as well. So we've had so much conversation in terms of just how this area of healthcare is just booming. And, I'm just reiterating so much of what was said today. If you look at the 13 county Gulf Coast region, we have about 7.3 million people in our area. It's huge. I know that, oftentimes you hear people say that you can fit the entire state of Rhode Island in Harris County. So you're looking at this region, which is the largest workforce board in the state of Texas. So in terms of the location of the healthcare jobs in our region, 94% of them are in the areas that are in blue. That's Montgomery, Harris, Fort Bend, Brazoria, and Galveston County. And then you have the rural areas that surround our region, and that comprises about 3% of the healthcare jobs by comparison to 97% of the healthcare jobs in the counties that I expressed before. And so we know that in this region, we are experiencing both the challenges of what urban and rural Texas faces. And so it's a very, as they say, as Houston goes, so goes the rest of the state and the country. But this 13 county region is truly a great indicator of what's happening in the state. Now, I tell folks, it's like, oh my gosh, you need glasses to see this. It's a listing of our non-allied and allied health professions. And so, as you look at this list, think about the person that presents to the career office looking for an opportunity in a new career and trying to figure how our career advisors can counsel persons about these different types of professions in a limited amount of time, but connecting them to the right resources and information they need to make good choices about their careers. So you're looking at the projected shortfall in non-allied healthcare jobs. And once again, it's just a demonstration of our region having these challenges. We have a 19% shortfall in the larger urban areas, but a 29% shortfall in our rural areas. So as was said earlier, the urban areas are experiencing the challenges, and the rural much more dramatically as well. In the allied healthcare professions, you also see the projected shortfall, with it being larger in the urban area than in the rural. But once again, these are some challenges that we definitely are going to have to face. I provide this as a labor analysis snapshot by comparison of the various workforce boards throughout the state of Texas for your records. And, sometimes people say, well, build more nursing schools. Maybe we can, get more folks admitted and it should alleviate the shortage. But as people explained today, things are much more complicated than that. There's the need for, having the preceptor shortage addressed, the clinical settings available for the students, and, just making sure that we can have a system that's much more enhanced and coordinated with the right mechanisms and capacity and personnel to be able to address the shortage. And as we also discussed earlier today, it's not just nursing. We're seeing hospitals employ individuals and over 2,500 occupational codes and shortages adversely impacting care, and, hospitals having, having to not have their beds at full capacity because of the challenges in terms of the workforce issues. And while we are trying to utilize technology with telehealth and other types of opportunities, this is an area which we can continue to explore. So in terms of building capacity, we have an extraordinarily rich ecosystem in the Gulf Coast region. The Greater Houston Partnership and its Upskills Initiative has worked significantly in this area. There's the state of the Texas Medical Center. There's BioPulse events. Local chambers also have opportunities to focus on healthcare and life sciences. And I've already mentioned just the tremendous growth and leadership and innovation at the Texas Medical Center. Now, Workforce Solutions, as we work with our partners in the region, we are trying to develop employer-centric solutions to their issues and also develop rich collaborative opportunities with our K through 12 and our post-secondary system as well. And the Texas Workforce Commission has made investments, as was described earlier, in certain types of grant opportunities. For instance, we have Jobs Y'all events in which we allow the K through 12 system and post-secondary to come and have an opportunity to explore job fairs and career explorations with various partners. And we also applied for the Tri-Agency Regional Convener Grant. and have been working in that, which I will share some more information. And also, there has also been investment in the school systems as well, and partnerships that go on between employers as well as the K through 12 system. So Memorial Hermann and Aldine ISD have launched an innovative healthcare program that has also been supported by Bloomberg Philanthropies. And Bloomberg has also supported another Uplift Charter, as well as efforts to try to formulate relationships with Baylor, Scott and White and school districts. And then HCA Healthcare has worked on PTech academies as well. And so you see this opportunity that also is another example of like DeBakey High School in the Houston Independent School District. And so I tell folks oftentimes when you have these rich collaborative opportunities between employers to help guide and provide support in the development of curriculum and experiential opportunities at that K through 12 level, it can really give open doors for youth in that space and place. And I also want to say thank you to the philanthropic community for also investing in this area as well. So the Tri-Agency Regional Convener Grant that we received was a $600,000 grant in which we were working with the education service centers. There are 88 school districts in our region. That is not including the charter schools. That is not including the private schools. 88 school districts, that's a lot. And so what we are trying to do is work with the educational service centers that cross-sect our region 3, 6, and 4, and try to work with partners as well as our post-secondary to develop career pathways, give young people experiential opportunities, immersive opportunities as well. And these are tied into 7 components of what does it mean to constitute a high quality pathway. And you'll see in this photo, we were able to partner with the ION to bring 75 students and teachers as well to the ION to come and talk, listen in to lectures from persons in industry that talked about healthcare, building and construction, and education. I have a brief video that I don't know if I can, well, we'll skip over. It should be in your file and review, but it talks a little bit about that ION experience. And what we found is that young people, including those that are in career technology education programs, they still need more information. They still crave information. They want to interact with people that are currently in industry. And I will say that the panel that we had with representatives from private industry was the one that they rated the highest. So with the funding from the Tri-Agency Convener Grant, we had an opportunity to send 75 students to have a live-in experience at Rice University. They were there for a week. They had an opportunity to visit the Texas Medical Center, the opportunity to go to meet with people, talk to industry experts, speak to professors, and I was surprised at how interested they were in learning about labor market information. And so they had a poster presentation at the end talking about careers and what they had learned. And so this was an opportunity for us to open up the ivory tower for individuals to have easy access to the medical center and just have an immersive opportunity for young people to have to experience more about the community, what exists in their own backyard. And we also used funding to be able to give paid internships to 14 students to be able to work at HCA Healthcare and Access Health. Another part of the grant funding is going to give youth immersive experiences and paid employment at building and construction and education as well. But we are extraordinarily proud and grateful to our partners who are participating in this program, giving young people the opportunity to get a paid work-based learning opportunity at a healthcare setting. And so, you look at the different types of opportunities that are presented before us and trying to give these persons a chance to have earn and learn. And so I tell folks, we are just very grateful in sharing that the U.S. Department of Labor recognized nursing as an apprenticeship program. And there are other opportunities available for radiologists, CMAs, CNAs, sterile processors, and phlebotomists as well. This is an opportunity for us to really try to dig in deep, to work hand in hand with industry to develop pipelines of talent. And so, we are also, as we had talked about earlier today, bolstering faculty, preceptors in nursing, and trying to, look to see how we can serve as a support in this area for our local healthcare providers. And, we've examined some innovative practices looking at mobile clinics, non-traditional hours, centralized scheduling. I will tell folks that we had an opportunity to work with one of the community colleges who typically had a program that lasted 12 weeks, but they were able to collapse it to 3 weeks. And so we see how there are opportunities if we can design and develop cohorts to provide some more wraparound services and supports, that the community colleges are very flexible and willing to assist us in trying to fast track training as well. And so looking at internal employer-based training, we're trying to leverage funding, braiding those dollars from Workforce Solutions, the Texas Workforce Commission, and the DOL to learn about ways in which we can help folks grow their own employees. And we also want to incentivize tuition assistance and tuition reimbursement program to help with this internal upskilling. And then explore partnerships with post-secondary institutions offering virtual instruction, flexible training models, and as I mentioned before, that fast track opportunity as well. So these are just some examples of some initiatives that we've had with various partners. We are currently working with Houston Community College and Dwyer Workforce to upskill certified nurse assistants, and they're also on track to continue on a career path while they are in that program as well. We assist them with wraparound supports such as transportation and childcare, as well as tuition assistance. We've been working with HCA Healthcare in a partnership for the development of an apprenticeship program with them as well, investing in CT technologist training. And with MD Anderson, this is something that just happened more recently, looking at opportunities once again of developing apprenticeship programs for these different areas, everything from med techs to addressing the radiological shortages as well. And we have also developed a partnership with UTMB. And one last slide that I wanted to share is a partnership in collaboration with the College of Healthcare Professions. We recently received a grant from the Texas Workforce Commission for upskilling, and we wanted to focus it on healthcare. And so in that area, we worked with the College of Healthcare Professions to start designing and developing a cohort model. We found that when students are able to go in together as opposed to one-on-one individually, it creates a better sense of community, an opportunity for them to work with one another and, develop, strengthen that social network working together. And so we are using this as an opportunity to examine our system, see how we can make it more efficient, but we're also partnering with local media. And so Nick Notario, who is an outstanding reporter in Houston, has allowed us to use their system to be able to promote our job fairs, to be able to talk about different types of opportunities that we have. We actually have we've already had a job fair and a 30-minute show focused on healthcare, and we want to be able to do more. And so we are looking at all different sorts of ways of braiding our resources, working with our partners to be able to promote the needs in this area, but also the great opportunities that exist with our local post-secondary institutions, as well as scholarship opportunities. And so with that, I thank you for your time.
Thank you so much. It sounds like an incredible amount of innovation and attempting to address really all of these different kinds of healthcare professions there at the local level. Clearly, the Gulf Coast is unique with the medical center and UTMB and Galveston. When we talk about scalability, are there pieces of this that you think could be applied in other regions?
I do. I think that, if there's some way for us to be able to create a network of best practices, sometimes or even a playbook, when there's opportunity for innovation, it should be captured and shared with others. So that way they can use it as a model to consider. Every community is unique and different, and that's a blessing in terms of people being able to design something that meets the unique needs of the communities that they serve. And so, I tell folks the DeBakey High School is great because of its affiliation with the Texas Medical Center. I tell folks that you can say that the High School for Performing and Visual Arts is great because of their connections to the arts communities. And so when you see young people that may not have had an opportunity for their parents to be in a certain type of profession, we look to enhancing the social capital and networks by bringing in the employers to share what opportunity is available. And if the students are able to have that interaction with someone, then it creates a link for them to have more motivation and understanding of their future.
Great. Any other questions from task force members? Thank you very much for being here today. We really appreciate it.
Thank you so much.
And so next we have Workforce Solutions of West Central Texas, Mary Ross. Thank you so much for being here today.
Thank you for inviting me. And I want to say thank you to my colleague who preceded me, because she did a great job of explaining the workforce system. So I don't have to go into a lot of detail about that. My name is Mary Ross. I'm the CEO for Workforce Solutions of West Central Texas. We are kind of the opposite end of the spectrum from Houston. We are very rural. We serve a 19-county area, about 18,000 square miles and about 329,000 population. So, you know, a lot like Houston, just take the 7 million off and that's us. We also have a lot of school districts. We have 63 school districts in our region, very rural. About 60% of our population is in a rural county. 40% or so is in Abilene. And then our other 18 counties, very sparsely populated, like one person, like 18 people per square mile. So quite a bit different than our Gulf Coast friends. That's a little bit about our region. Of course, healthcare, very important in our rural communities. As you all have heard the data about the lack of availability, we have a couple of counties that don't have healthcare facilities at all. Not many hospitals. Many of our counties are served by rural healthcare clinics. We only have one major hospital in our region, which is Hendrick Health Systems. And then every other hospital is classified as a rural community hospital in our area. So, like I said, big contrast from a larger urban area. We are fortunate that we do have nursing programs through our community colleges and also through a university. And our supply and demand is not, frankly, that much off when you look at the numbers of what we're actually producing and supposedly what is needed. But unfortunately, what we do see is that many folks who come into our region and go to school leave our region. If they are coming from outside of our region to attend school, they often go back to the larger urban area where they originated from. So we're not always retaining all those folks. If we could retain them all, then we'd only have a differential of about 10%. But instead, our differential is closer to 30%. Folks come in, go to school, and return back to larger metropolitan areas. So I'm going to talk really about a couple of areas that we focused on. Much like Gulf Coast, we're also a tri-agency convener. We also do training through our community college partners, et cetera. But we have invested a lot of our resources and time for, honestly, the last probably 15 years almost in looking at how do we grow our own workforce, because our population is not growing as dramatically as it is in urban parts of the state. And so our best solution is really to try and retain the workers that we have in our area, retain those students. And that means we have to make them aware of what the job opportunities are in our own region. So we've had a career awareness kind of initiative and a person who was focused on that, like I said, for about the last 15 years or so. Started very small with one person who went out to some schools and did some career awareness kind of presentations, to now, for the last 10 years, we've done a big regional event called the World of Work Youth Expo that brings in about 2,500 students from 56 of our school districts typically. So most of our school districts are coming into that. We also have staff who go out to middle schools and high schools and do regular presentations on the occupations that are in demand. And we typically do that kind of 1 month, maybe manufacturing. And so that may be like in October, which is manufacturing month, manufacturing awareness. Then we'll do healthcare careers. And we talk about what are the jobs that are available locally? Where can you go and get education? What programs exist? So we have a lot of maps that show you can go to this community college. Here's the pathway for you to start from your high school on. Here's what you take in high school. Here's what you would do at a community college level or a four-year level, so that those students can see there's a pathway for me starting from the time that I'm doing my plan in 8th grade all the way into whatever level of education that I may want to go into. So that's been a focus for us for the last, well, we had funding from the Texas Workforce Commission for what's called a Career and Education Outreach Specialist Program. And so we have those staff who go out into the schools and do those presentations, and also focus very heavily on employability skills, because we all hear that often from employers, that young people are always on their phones. They don't know how to interact with folks in person, actually, et cetera. And so that's a big part of what we also talk about. So I want to kind of talk more detailed about a couple of initiatives that we think are beneficial and good strategies for addressing the shortage, not just of nurses, but allied health professionals. Like I said, from probably a slightly different perspective than what you all may be used to hearing about. Like I said, one is really looking about growing our own. And Juliet mentioned this about doing work-based learning. We have been focused on work-based learning, which we define as anything from an industry tour to an actual paid internship. And so everything in between. It can be job shadowing, it can be unpaid internships, and can be paid internships. So we really invested very heavily into a pilot this last year on work-based learning, and have actually had an outside evaluator look at the pilot and and come up with some results, but was focused on rural school districts. So we piloted this with 8 of our rural school districts. And when I say rural, I mean these are schools that often have 6-man football, for those of you who are into football. So we're talking relatively small districts in small communities. And so there's not a lot of employment opportunities sometimes in those areas. So in this pilot, we worked with our largest hospital at Hendrick Health Systems. We also worked with 2 rural hospitals and 2 rural health clinics as the sites for our work-based learning. The students had an opportunity to do a job shadow day, and we worked with high schools to try and find either programs where they already had pathways of study that were focused on healthcare, or if they didn't, then they had some allied science courses. And so we worked with the teacher and said, we want to come up with an opportunity for your students to go and visit an employer. I will say that visiting with employers, and this was very much driven by working with employers first. And I'll get to that more in a moment, but there's a lot of challenges tied to bringing students into healthcare settings, as you can imagine, when you're talking about bringing 16, 17-year-olds into a healthcare setting. We did this in healthcare and manufacturing. We decided if we could make it work in those 2 sectors, it could probably work in any sector, because of the safety and the liability and the concerns around working with underage students. And so for healthcare, the students went and job shadowed, and they either job shadowed at a hospital, at a clinic, or even at a nursing home. Students and the employers had to evaluate it, and it was a fairly lengthy experience, and you had to say, what did you gain from this experience? And the employer was also assessing how engaged were the students who came to that experience. This happened in the fall. The students had some employability skills training. Then in the spring, we connected those students who were interested, and we said, you can apply for an internship, a paid internship. To be honest, we were a little concerned that we might have a lot of students that would apply who might not be good fits, but not surprisingly, I guess, what happened is the students who rated the job shadowing experience as being very, very helpful were the ones who actually applied for the paid internships, which was great. We asked the employers to interview as many students who were interested, and they graciously agreed, even though most of them said, I can only afford to hire one financially, because the employers were actually paying the stipends, and these were 50 to 150 hour internships during that spring semester. We did another employability skills before the students went and did the interviews on how to do applications, interviewing skills, resume, etc. Ended up placing students in the rural hospitals. We had 7 students who were in those rural hospitals, health clinics, etc. They all completed, and 3 of them actually got offered jobs at the end of the time. Some of them were seniors, some of them were juniors. So they actually ended up going to work for those employers. Then our larger, employer, Hendrick, they took 19 students because they had more capacity to work with the students. 17 of their students completed. Now, these were students who were coming from rural districts, so these were not students in Abilene. These were students who actually came in from outside of Abilene to that larger hospital, and they ended up also hiring one of their students. So then we asked, based, like I said, on our evaluation with our third-party external evaluator, and over 90% of the students rated the experience as a 8 out of 10, with 10 being like fantastic. 62% of them said it was a 10 out of 10. It was like best experience they'd ever had. 90% of them said this would make a difference in their career pathway. It had made a huge impact on them and was helping them to figure out what they were going to do, and was incredibly valuable. The employers also felt like it was an incredibly valuable experience, that they were giving back to their community, and they were also getting opportunity, and were amazed, honestly, at the work ethic and the interest and engagement of the students. So it was a great way for those employers to see that there are high school students out there who really do want to go into the healthcare field and are interested. So we're hoping to scale this bigger going into the next year, and also into other industry sectors. Like I said, we just did this with 2 sectors to begin with. Then the other area I want to talk about, and you'll see there's a flyer there in your folder that's about the PACE program. And this is a collaborative partnership in conjunction with Region 14 Education Service Center, West Texas AHAC, the Big Country Branch, Hendrick Health Systems, and Workforce Solutions. This was has really been a long-term project that started probably last year, of recognizing, as you all have said, that certified nurse assistance is often kind of a foundational job. That's the pathway that leads to many other jobs, whether that be nursing or other allied healthcare. But in a rural community, it's pretty tough to find an RN, and one who has the qualifications. And it's also really tough to find clinical sites, as you all have said. So through this project, the Education Service Center actually has a registered nurse who meets all the qualifications to do the instruction. So it's going to be asynchronous instruction, working with 9 different school districts, starting in the fall. It has to be done that way, honestly, because their schedules are also different as to when they can offer this certified nurse assistant training program. They have to have 3 students minimum, and in a large place like that would be great. For some of our rural districts, 3 is, that it may be a struggle for them. They have to have a teacher in the classroom that's a preceptor. It's not just has to be a certified teacher that's in the room. And then their clinicals will be done either at a nursing home or a hospital. School will provide transportation to get them there, which is great. The school will also provide a setup for each of the schools will have their own classroom area with a hospital bed, for instance, and a wheelchair, et cetera. This is a really great example of collaboration because some of our school districts don't have a lot of money, not a lot of resources, didn't have enough money to really buy a hospital bed, for instance. We figured it would be about $8,000 for them to get what they needed to outfit a room for this program. And that was not within their budgets. But thankfully, because of our hospital partner at Hendrick, they said, I think we have some spare hospital beds that we could donate. So they did. So they have donated hospital beds to all of the districts that needed those to get started. And one of our local foundations came along and said, if there are other things that you all need for this, then we will also provide the financing for that to happen, which is wonderful. The schools will actually pay tuition, which will help cover the travel for that nurse who's going to go out actually to each of those districts and help with those clinicals. Again, those clinicals, that was an interesting experience because the sites did not meet the accreditation requirements to do the clinicals. So that's taken about 6 months with work from the Education Service Center, AHEC, heavily to work on helping those nursing homes and hospitals in some cases meet the requirements they needed to meet in order for those students to do the clinical rotations. So that's pretty exciting. The money, though, like I said, for the tuition will pay for the instructor and for her travel to go out to the districts. But because these are all new programs, and you talked some earlier about dual credit enrollment, some of these will be dual credit. Some of the districts do not have enough of a pathway and they don't have the right instructional capabilities to do dual credit. That is ultimately the goal and the hope that these could be dual credit, but it doesn't have to be for the district to participate. But because it's a career and technical education program that has not existed, it will increase the weighted funding to the school district. So it will offset the cost of the $650 that they're paying to the Education Service Center. They will realize, in essence, that much revenue to the district because they've now added this career and technical education class. So in essence, it will be a wash, which makes the program more sustainable financially for the districts. As I said, this is a pilot, and you see there's a flyer in there. We've got another 6 districts or so that are standing by and wanting to join in, and we're hoping that this will be a program that will continue to scale each year as we see more districts are interested, and that by having a single instructor who can deliver that content, then it makes it affordable and feasible to do even in a very rural setting. So the challenges, I guess, that I would share with you is obviously, capacity. Capacity is a big issue, whether you're in a large area or in a rural area. In our case, capacity is an issue because there's not a lot of resources. There's not a lot of, large employers. There's not a lot of big foundations and folks who are able to put money. So collaboration is really a key. And figuring out how we're going to be able to scale this to where we need to get it. It also takes a lot of time and to make this happen. This PACE program will have taken about a year to put together. So you don't do things quickly. You just have to invest the time that you need to. Our work-based learning pilot, again, we probably spent easily a year before we actually launched the pilot. We spent a lot of time talking to employers about what are you looking for when you have a student that comes into you? What are the expectations that you have? Many employers are willing to do internships, but they want to know that the young person coming in is prepared. Yeah, and so we spent a lot of time figuring out how do we help prepare students? How do we make this a good experience for the student and for the employer so that it's a win-win situation? And, honestly, our employers are not large. We're fortunate that we have one really large hospital system who is an incredibly great partner who we work with on a variety of initiatives. And if it were not honestly for a lot of their leadership, it would be difficult. Although we have some great rural hospitals and clinics, their capacity is limited. They don't have extra personnel to invest. So, some of our clinics are really, really small and taking even one student on for them is a challenge. But it's worth the time and investment if that one student decides to go into a healthcare profession and then leads on into whether that be into nursing or lab or higher up degrees and certifications. So we think kind of the best practices and things that have come out of this is clearly doing a lot of the work up front, engaging with employers, making sure that they are bought in and that it's really driven by what the employers are needing. In this case, the hospitals, the clinics, et cetera, and the nursing homes, because we have lots of nursing homes in our rural communities, even though we may not have clinics or hospitals. And that does provide an opportunity for good employment in a rural community. We also think the collaboration is essential. Sometimes my colleagues in larger areas talk about the challenge of getting everybody in the room. That's not a real big deal for us, honestly. We can often get all the players into the room because we all know each other, because there's not a lot of us. There's only so many folks, community college folks, and so it's easy. We're fortunate that our Education Service Center sits within our region completely, the one that we work with, although we do have 4 others that have parts of our numerous counties that serve some of our other counties. So we collaborate primarily with 2 of our Education Service Centers who serve the majority of our counties. And then we've got 3 others that serve like 1 county here and there. But our Education Service Center is very good, Region 14, on bringing those folks in. But again, collaboration among programs and partners, community college, higher ed, K-12 system, and our community agencies like AHEC is essential for us in a rural community. The majority of our employers were able to pay the stipends to the students themselves, which was great. But we did have some flexible funding that we were able to pay those stipends, and that's essential. You've got to have that, especially if you're in a rural area where you want to provide that in that paid opportunity, but the employer just may not be able to afford to do that at the scale that we would find desirable. And so that's really important. And I think the other important thing beyond collaboration is you really need to have an intermediary organization often who can bring everyone together and make those connections. In our case, we have served in that role in some instances. Our Education Service Center has served in that role. Many of our employers and our school districts said, we could never do this if it were not for you all coming in and helping us. They don't have the capacity to go and make those connections to whether it be an employer or higher ed, or to put together the curriculum. As I said, they don't have the funding and they can't attract the staff that they need to actually deliver the courses that they would need to deliver in high school. And so for them, having an intermediary that can come in and say, I can bring all these pieces together for you, whether it be work-based learning or the training in your school, is seen as highly valuable. We do have some opportunities for improvement, and we know that again, based on our evaluation, that we're going to have to figure out how we get those experiences of the job shadowing and the work-based learning tied together a little more quickly and closely, so that we can help make that a even better experience for both the employers and the students. The teacher said, this is great. The paperwork is a little overwhelming. And I know someone alluded to that earlier of the documentation. I will say, yes, there's a lot of documentation. And as I said, getting students into the healthcare sector, into a hospital setting, frankly, really challenging. Like every student had to have TB tests and, everything, as you all know, just a job shadow, not to do anything else. And so, trying to figure out, are there ways that we can streamline that and make that easier? Because like every student that went to Hendrick had to have scrubs, and every student had to have, like I said, background checks and various other things. I think because the hospital didn't really have a way to look at those students anything other than they're coming in like they're doing a clinical, even though they literally were only doing a job shadow. So he said that may be an area, if we can figure out, you still have to obviously protect the privacy of patients, and you have to ensure that you have the safety and that students are aware of those things. And it's clearly much more than a tour, but it's also not a full-blown clinical, but a whole lot of work and time going into that. So figuring out how can we improve the processes to make perhaps that easier for both the employer and the student to make those connections. And with that, I will close and be open to any questions that y'all may have.
Thank you so much, Mary. That's an incredibly, that's like the true definition of bootstrapping something together, and the way that you all, you all built that. And it actually leads me to some questions for the Workforce Commission, before we move on. Does anybody else have a question of Mary? Okay, so for the Workforce Commission, obviously we've heard two very different stories of two very different regions building two very different types of mechanisms to get folks into their workforces in the healthcare field. How does the Workforce Commission from the statewide level support those programs? So, great. So could you come up, please?
Good morning.
Morning.
Mary Ballast. I'm part of our Workforce Development Division, oversee our workforce education programs. Glad to be here.
Thank you so much, and apologize for putting you on the spot, but it's interesting. I think some of the things that we've just heard about were grant eligible, some of them were not grant eligible. kind of just bring us up to speed a little bit on where the Workforce Commission fits into supporting those local boards and those innovative projects.
Thank you. Well, one thing I've heard mentioned across several of your speakers, for instance, of the apprenticeship program. So through TWC at the state level, we are able to support registered apprenticeship programs, which are those that go through Department of Labor registration. We're also able to support the apprenticeship model in general through funding provided through our legislature. So in this, we have already issued grants to large and small hospitals and hospital systems to support registered apprenticeships. Through that funding, they're able to cover the instructional cost of those future healthcare workers. We also, especially for our registered nurse healthcare apprenticeship, are able to provide a stipend for the participant while he or she participates in the clinical. We had heard very often that sometimes that's the biggest challenge for someone who's trying to complete a clinical while still trying to maintain a job somewhere else as they do this. So through that, for a moment of just, I would like to brag for just a moment. It was Texas who put together the first set of RN standards that were approved. And so we did some really great groundbreaking work there and in introducing this model to our hospitals, mainly to address what we heard as some of the major pain points, such as high turnover rates, and a good, steady, predictable pipeline about who can and who will be available to them in the future as someone that they could work with to become a registered nurse. And so that was one. On the other side of it, and I've heard mentioned too about work-based learning, we're very much about supporting and putting funding behind any kind of training that allows someone to be in the work setting and working as they learn. So we call this the Earn While You Learn model. So we're able to put funding too behind short-term training for hospital systems in which, for instance, they're going through a grow your own model and they're seeing that they have entry-level employees who have expressed a desire to move up within their system. And by virtue of a short training, for instance, we have been working with a healthcare system in the Gulf Coast area that realized they have many food service workers who were wanting to become psychiatric techs. And they realized through training, which they had put it at about 8 weeks, they could begin to move current employees into these much needed positions that they had. We also, through this, we call this our Texas Industry Recognized Apprenticeships. And through that model, we're able to cover the cost of the training of systems, training current employees into new positions within their system. So that's also another approach that we take. References to, for example, what's going on in high schools and the education outreach specialist. That funding typically starts at the state level, and we're able to support those specialists who are housed in some of our workforce offices and within our workforce areas. Other boards have found ways to hire and retain their own education outreach specialists. And the goal there is to be in our high school classrooms and with students to tell them about the opportunities available to them through healthcare, through our JET grant program, which is Jobs and Education for Texans. We're able to work with colleges and school districts in making those large equipment purchases that are needed for training. And so we have a very robust program in equipping classrooms for this type of training. We're also able to, through what we call the Skills Development Fund, to work with employers to upskill current employees or new or current employees. Again, referencing back to that training of looking at your current workforce And knowing that through a short training program, that you may be able to move them up to a whole new set of skills or add to what they currently know based on the technology that's emerging, the new needs that are emerging within their systems. I think I've kind of done an iceberg right now. That's the tip.
Yeah, that's very fair. And we'll probably have you come back and maybe talk to us a little bit more formally. Do you have any idea in the scale of what the agency does in all of these programs? The context or just some estimate of how much of that gets focused on healthcare and how much of that is on other, and I know it'd be a pure guess, totally understand.
And true. So I won't, I'll trust you not to quote me.
Yep.
I do know that for our three commissions and especially for our chairman, healthcare has been first and foremost a huge focus. He convened a work group last year of hospital systems, rural to our larger ones across the state, to hear from them. Upon that, that's when we started to put large swaths of funding behind helping build these programs. So I would say right now, because our economy is doing so well and because our unemployment levels are so low, we have the luxury of being able to focus on industries and occupations that truly have the greatest need now and in the future. And so for that reason, healthcare has been a primary focus of the commission for quite some time.
Thank you. Any questions for? Great. Well, I thank you very much. I apologize for putting you on the spot, but that I think was good, helpful context for us going forward. And we'll work with you again on some of the next steps. So thank you. Thank you. All right. Next, it's the Texas Hospital Association. Jennifer Banda. Yes.
Good afternoon, checking my watch. Madam Chair and members, it is nice to see you all here today. We very much appreciate being invited to talk today about workforce and the challenges we see in the state and the importance of growing the healthcare pipeline. I am Jennifer Banda, the Senior Vice President of Advocacy and Public Policy at the Texas Hospital Association. And I want to talk today really about how it has been a long time, decades-long priority for the Texas Hospital Association to look at really not just the pipeline issues that we have in healthcare, but also to talk about, some of the things that we do to make sure we're retaining our workforce too. I've appreciated some of that conversation. I want to talk a little bit more about that toward the end. But really what we're talking about today, we're not just talking about the workforce needs of the state, but we're also talking about access to care and about the cost of healthcare, because workforce, of course, plays into all three of those elements. I will take the liberty of re-quoting some of Pam's data from earlier. When we really look at, our workforce needs in the state, that in 23 Texas nursing schools turned away 13,705 qualified applications. Now, even if you take into account those duplications that she noted, that's a significant amount of people, particularly post-pandemic, that still want to go into healthcare and want to have those jobs. Also, her data showed that the RN vacancy rate and the LN vacancy rates, particularly at hospitals, have both increased significantly post-pandemic. So we have the people that want to do the work and we have the jobs. We've got to get them through. And we've heard today the choke point, and even Pam said, for the last 10 years or so, has been the clinical sites and the faculty. So continuing to keep an eye on that. Just in terms of access to care, we did a survey of our members in 2023, and 64% of Texas hospitals had operated at some point in the immediate prior days with fewer beds or had to reduce services because of lack of staff. So when we don't have the staff that we need in the healthcare setting, and particularly in the hospitals, it is an access to care issue. And I don't ever want us to lose sight of that, because I think that's a really important point. And then I want to just also note that it's a cost of care issue as well. And I have some statistics to talk about that. You know, historically, workforce costs are about 50% of a hospital's total expenses. But the labor costs during the pandemic in particular related to contract care. And, you know, since the pandemic, labor costs have increased to the point that between 2021 and 2023, it is now about 60%. Labor costs are about 60% of an average hospital's expenses. So it's a significant increase there in terms of the cost of care, something that everyone in this building in particular wants to focus on. And I know certainly patients do too. The continued use of contract staff, it's leveled off a little bit. It's still out there. That adds to financial challenges that hospitals face, especially true for smaller rural hospitals where the local workforce pool is smaller and it's harder to recruit staff. The growth in wages and benefits has surpassed economy-wide inflation in the last decade. So again, staying focused on the cost of, you know, the impact to cost is important. And this isn't just a hospital issue, and it's not just a nursing issue. Nursing and allied health shortages in long-term care and in rehab and in home health, those things impact the rate of discharges from hospitals. So when we can't discharge a patient from a hospital, that patient has to spend longer in the hospital. That's impacting their patient care and certainly impacting their cost of care. So hospitals have shortages of nurses, not as representing the hospitals, we have shortages of nurses, but also of all the allied health professionals. So we focused a lot on nurses today, but I know we will have much more conversation about not just nurses, but all the allied health professionals, because we, again, want to keep looking at the access to care issues, the workforce issues, and the cost of care issues. So from a THA perspective, a few recommendations and things that we hope you will keep an eye on as you move through the work groups and move into a recommendation stage. We strongly support growth at all of the nursing schools, you know, all types of nursing schools, and growing all the different levels of nurses across our state. We know that the pinch point is faculty and clinical sites, but we need to be looking at, you know, the community colleges, the 4 years, and the health-related institutions all across the board. We strongly support the legislature's work on Senate Bill 25. We really appreciate the Lieutenant Governor and Senator Kolkhorst's work on Senate Bill 25. We have been longtime supporters of the Nursing Shortage Reduction Fund and the Nurse Faculty Loan Program, which Senate Bill 25 allowed part-time faculty to also get those loan repayment programs. And we think that's important because we can, you know, increase faculty by increasing the number of part-time faculty that we have, not just full-time faculty. And then the effort on nursing scholarships as well. We hope those programs will have an impact in this coming school year. So, you know, we support the effort, and we know the coordinating board is working hard to get that money out the door, those rules finalized, and make sure that we can have an impact as quickly as possible. We support the conversations and the efforts to make sure that we have clinical sites beyond hospitals, FQHCs, long-term care, home health, all of the other settings out there that can do clinicals. We think that is important. It helps grow where we can have the clinical sites, but also people can find their passions in those settings, and that's important as well. For clinical expansion inside of the hospitals, preceptors take on an extra responsibility by supplementing faculty, and they are essential to training new nurses, and they are needed at all of those nursing education levels. Senate Bill 25 created a preceptor grant program, but it wasn't funded. I encourage you guys to look at that as you're considering that. I know, Madam Chair, your question earlier was, what was that recommendation from last session? Last session, it was 82 million for the biennium, but the Teaching Hospitals of Texas, who put that number forward, they're looking at that again to making sure they have the very best number coming into this next legislative session. So we will update you with that and make sure that you have that when that is available. when it is possible, we would like to focus on funds to create new bedside nurses. What we hear again and again from our hospital members is that the biggest nurse recruitment challenge in every area of the state is bringing in those new bedside nurses. And there's a lot of opportunities in the nursing field, and it's a wonderful thing to progress through your profession, get additional certifications, degrees, and move up the ladder. But we really need to make sure we're continuing to grow those new nurses and new bedside nurses. We've had discussion about this too, and I know you have work groups set out to do this, but making sure we're examining the totality of the workforce shortages, medical assistants, surge techs, even the ones that, we all learn every day, or I learn and others learn every day that is, a profession that's out there, a new certification, a new registration, making sure we're growing all of those allied health professionals, because when we have that growth across the board, it allows the full care team to be able to practice at the full level and provide the very best patient care that they can in that team-based setting. And that is important. And that also helps prevent burnout when people are being able to do, what they really came into their profession to do. And it improves access to care for the patients. I have really appreciated the discussion that we just had about looking at the successful partnerships between hospitals and providers and industry and education, looking at K through 12, looking at preceptor programs, looking at PTECs, looking at all those career pathways, because I know that our hospitals are doing a lot to engage younger and younger students in the healthcare workforce. And I think that's important. The Workforce Commission has been doing a lot of work in making sure those grants are out there, engaging hospitals in that work. And I do think that's something we can try to really dive deeper into and kind of amass what is working well and scale those things up that are. I think that's an important thing because there's a lot of work going on all across the state, as we heard today, in those areas. We want to ensure that Texas continues to grow its physician workforce as well, not to lose sight of that. Maintaining the GME slots at the 1.1 ratio to Texas medical students. Our legislature has been very diligent about doing that. I think that continues to be important from a workforce perspective, and making sure we have those loan repayment programs that incentivize where we really have challenges recruiting physicians, family practice, rural doctors. Those, the legislature's been diligent in funding that. And I think those things continue to be important. And then the last one I will mention, because it's really critically important all across the state, is our behavioral health workforce. Almost every county in Texas today is a behavioral health workforce shortage designated county. The coordinating board has a mental health loan repayment program. It was funded in prior years at about $2 million. The legislature upped that to $28 million last legislative session, a huge increase in focus on our behavioral health workforce. And that's for all behavioral health providers, from psychiatrists, psychologists down the chain to those people that really have access to the people that need behavioral health care. And that allows those providers to practice in mental health professional shortage areas. So I encourage everyone in this room to promote that program, because we want to make sure that people that are eligible for those loan repayments are applying for them. It is encouraging people to go into that space and making sure that program grows successfully and can be funded again, because that is a critical shortage all over the state and makes a huge difference for so many Texans. And then I will just say, THA has a long and proud history of partnering with our Texas Medical Association and the Texas Nurses Association to ensure that Texas is a good workplace, with a focus on patient safety, a focus on workplace retention. We want to continue to do our part to ensure that Texans stay in the workplace. THA helped with and strongly supported the new Workplace Violence Prevention Act that has gone into effect and should be in effect for every healthcare provider this fall across the state. We supported the first in the nation flexible, safe staffing law, our Texas peer review programs, and the creation of the Center for the Nursing Workforce Studies. And you heard today what a fantastic center that is in terms of providing the state with significant amounts of nursing and LVN data. And that's just naming a few things that we've worked on throughout the year. And we also focus, as Dr. Ward mentioned earlier in the day, Hospitals focus on extensive orientation and transition to practice programs because you really want to help ensure you're getting those challenges early on and you can keep people in the workplace when they've, when they have entered into the healthcare setting. I think it's incumbent on hospitals to try to make sure that we can retain staff and be a strong place to work. When we are here asking the legislature for additional dollars to grow the workplace in Texas, we want to make sure that those dollars are invested wisely. They produce fantastic people who will continue to serve patients all over the state of Texas. So I will stop there, Madam Chair, and see if there's any questions.
Thank you so much. Really great information and feedback. So I do want to, on addressing the totality of the workforce shortage, it seems like almost with for work group 1 that we're going to have regarding the allied health professionals and the other professionals that feed in, there's almost 2 objectives there. One is you just need more of them. And then you want to encourage them to advance their career, maybe become nurses, maybe become other professionals later on. But there needs to be an effort at the foundation to increase the number of allied healthcare professionals in and of itself, and the tools, making sure the tools exist for them to move on into the healthcare system and stay in the healthcare system as employees.
I would absolutely agree with that. And I might actually add a third one, but at the front end.
Okay.
Is making sure that we are able to capture who they are and what the shortage areas are. I think the data, we have some disparate data in different areas around the state. And I think just trying to identify where is that data located? What do we have or what do we not have and what is missing?
Yeah.
I think that is the first challenge. And then we figure out, what do we have that shows where we need to be focusing in those areas, and then how do we do it?
Okay, that's the data piece is an important one. We face that challenge between both the 2 agencies.
Correct. Yeah, I think, because it's in different places, the education happens in a lot of different areas. And so it's trying to figure out what are all those programs that are out there and how effective are they and what do we need more of?
Yeah, that medical ophthalmology technician that I mentioned earlier, he actually got his training on the job. And I mean, he's at Baylor in Houston. But he got his certification, but he got his training on the job for that. He didn't do that in any kind of education institution. So it's a tricky thing to kind of find where those people are.
Absolutely. So, you learn something new every day. I just learned
it. All right. Any other questions? Okay. Thank you so much, Jennifer.
Thank you all very much.
That's right. Now it's Torch. Good to see you, John. Come on up, everyone. This is John Henderson from Texas Organization of Rural and Community Hospitals.
Thank you, Madam Chair and committee members, for giving me a little time to provide rural specific context this afternoon. No doubt it's been a high content day, and so I don't plan to use all of my time unless y'all have questions. And I did have handouts, but I left them on my desk in Round Rock. So I'll provide those to you afterwards, and apologies for my mistake. My name is John Henderson. I'm the president and CEO of Torch, Texas Organization of Rural and Community Hospitals. So I work on behalf of the 158 rural hospitals in Texas. Been in this role about 6 years. Prior to that, I was the hospital CEO at my hometown hospital, a little community called Childress up in the Panhandle of Texas. I had in my slides a map of all the rural hospitals in Texas. You don't need that to understand rural Texas is most of Texas. Those 158 members are spread all over the state, although they're all rural. They come in different shapes and sizes. About 75% participate in the trauma program. About 40% still provide obstetrical services and deliver babies. That's something that's flipped in the last generation. There used to be 60% of our membership that did deliver babies, 40% didn't. Today it's 40% that do, 60% that don't, and we're trying to help them hold on to those services. As Jennifer mentioned, and THA does great work for all 600 hospitals in Texas, I get to focus on the rurals. we have some maps on primary care shortage areas. All of rural Texas is a primary care shortage area, essentially. And then when you look at that HPSA designation specific to mental health services, I think 251 out of 254. Williamson County, where I live, is not designated HPSA. I don't think Harris County is HPSA, but that's not just a rural thing. That's all of Texas is a health provider shortage area specific to mental health. I want to focus the remainder of my comments specifically on nursing. It's not to say we don't need lab techs and physicians, but nursing is probably the most acute need in rural Texas and illustrative of the other issues that we face. As Jennifer mentioned, about 13,000 nurses short, projected to be more. What's interesting to me is it's essentially the same number of qualified nursing student applicants that we turn down in Texas each year. So it's just a matter of syncing up the problem with the solution. And that one's a little personal for me because our oldest daughter just finished her sophomore year at Texas State and is applying to nursing school. She got in, thankfully, but it wasn't as easy as I expected it to be. And I don't want to be, I want to lay out some challenges, but I don't want to be sky is falling, because we do see some reasons for optimism and some momentum. So at the end, I'll mention a couple of programs that encourage me. The bottom line, people say, what makes rural different? The bottom line is that if hiring success comes down to the ability to provide some sort of financial perk or sign-on bonus, rural communities are going to miss out on talented clinicians. And that puts even more operational pressure on the most vulnerable hospitals in the state. Those are challenges. Reasons for optimism. As a state, I think we're making real progress with regard to broadband. And during the pandemic, we learned that we can work from anywhere. And I think more people are going to choose rural Texas as a place to live and work, a place that feels more like home. But we're just now learning how to attract the spouse of the clinician to those rural communities, and the families of the rural clinician to those rural communities that want to live and work in a place that feels like home. No doubt Texas community colleges do a good job of training local students for vocational careers, but travel burden is still an issue in the most geographically isolated parts of the state. So the further a student is from training, the less likely they are to complete that training. That's just the way it is. And usually, same as physician residency programs, where a nurse trains correlates to where they're going to stay and practice. Of note, rural hospitals and rural nursing homes don't necessarily need the most highly trained clinicians, but we do need to focus effort and create paths for upskilling CNAs to LVNs and LVNs to RNs without those folks having to leave the community or do without income. This is an oversimplification, but generally speaking, these are moms with modest income backgrounds. And so extended training or higher education that's far from home, it's not to say it's not an option. That's a tough thing for those folks to do. We really appreciate recent financial support from the legislature. Jennifer mentioned SB 25 specifically, and support from the Workforce Commission. We love loaner payment programs. We love apprenticeship programs, and we've actually got some momentum with regard to both that and the homegrown programs that Mary Ross mentioned. We really just want to give smart local kids a career path and a way to complete their training, because we believe those are the folks that are going to not only stay home, but spend their career in service to rural communities. I said I would mention encouraging developments. I'll mention two. The first is a consortium of Panhandle rural hospitals. They call themselves the Rural Nurse Education Consortium. In 2019, there was a group of 5 rural Panhandle hospitals and 3 colleges that established as a goal to reduce and resolve the nursing workforce shortage by producing LVNs and ADNs. The academic partners are providing the curriculum and conferring the degrees, and the hospitals are serving as clinical sites and actually helping pay the faculty. Not every rural hospital can do that, but I think their calculation was we'd rather invest in faculty at clinical sites than pay agency staffing costs. And I know there's been talk about the challenges around clinical sites. We believe that about 60% of clinical training in nursing programs can be provided in those rural community hospitals, and we're encouraging our folks to do that, and that the remaining 40% can occur at the tertiary hospital site. Again, that's less commute and makes it easier for those students to complete. And we see that as a recruiting tool too, and a screening tool. You kind of learn if those people are a fit or actually not going to be a fit. So far, that program, Rural Nurse Education Consortium, has graduated 120 nurses, 10 more LVNs and 10 ADNs last month in May of 2024. And I was proud to be in New Orleans last month when they were awarded Program of the Year by the National Rural Health Association at their Innovation Summit. So more programs like that in regions of the state, I think, is part of the solution. And then the last story, and it's a little bit tragic, but has a silver lining. A friend of mine named Jim Horton is the hospital CEO in Rankin. Jim is a nurse. He trained as a nurse. His daughter, Adrian, or his wife's name, Adrian. His daughter's name, Lindsay, and she was a nurse on the OR team at the hospital in Andrews, Texas, Permian Regional. Did not know that she had a heart condition, did a couple of cases, was having a normal day, went to the restroom between cases, and tragically died in the restroom. Jim and Adrian, after a few months of grieving the loss of their daughter, kind of decided we can sit around and cry about this, or we can try to make something good come of it. So they started raising money to do rural nurse scholarships out in far West Texas. And then they contacted us because they said, we've run out of kids in Lamesa and Rankin and Pecos and Monahans that we can do these nurse scholarships. Would Torch be willing to help us go statewide? We said, of course, and we'll help you spend money. And last year we did, I think, between 20 and 30 rural nurse scholarships. And we're going to do more. My hope is to train 1,000 rural nurses, and I have no doubt that that'll be a big part of the solution to the workforce challenges that we face. So I'm going to stop there. Happy to answer any questions y'all might have. Appreciate the time this afternoon.
Thank you so much. Any questions? Oh, Kathy, go ahead.
John, can you talk about the closing of rural hospitals in the last few years and the reasons behind that?
Of course. Texas led the state in the category you don't want to lead, which is rural hospital closures. We counted 27 between 2010 and 2020. Most years there were 3 or 4, most of them in East and Southeast Texas. The little bit of good news is we've only had 1 rural hospital closure in the last 4 years. St. Mark's Medical Center in LaGrange was that one, but we know that our members are vulnerable. Within that, there are 4 rural hospitals in Texas that have gone to a new federal designation called Rural Emergency Hospital. And I think they did that to avoid closure. Those are in Crosbyton, Anson, Marlin, and St. Augustine, but that has been a protected designation for those folks. So only 1 in the last 4 years, after at least 3 or 4 prior to that. Our hospitals are vulnerable, but they're also resilient and trying to continue to find ways to serve their communities.
So is that designation the same as critical access, or like they had to create a new one to kind of cover?
It's actually the first new hospital designation since critical access
okay.
about 25 years ago. And the short version is you essentially give up inpatient services.
Okay.
So they have an emergency room and primary care services only, and 23-hour observation, but not inpatient services.
Okay.
It's a new
And
designation.
at critical access, they have inpatient, but it's very few number of beds, if I remember right. Okay.
Less than 25 beds.
Yeah.
Yes.
Wow, I can remember things.
Have
Okay, go ahead.
Have you found that allowing nurses who are in your area to be employed, or getting them to be employed in your facilities, has been a problem? And if so, what do you see as a solution to that?
I'm not sure that I've experienced that personally in the communities that I've been involved or engaged in. When you say getting employed,
Well, so home growing in a particular area, is that working for rural hospitals?
the ones that are able to fund it. So, some of them, we joke and say they don't, they're trying to, not a joke, trying to make payroll. So they can't invest in these programs. But to the extent that you can invest in either a hospital staff member that wants to upskill or a smart local kid that doesn't necessarily see a path to college. And most of those are the mechanism is financial support for a commitment to serve the community. Those do work. There's no doubt they work. Sometimes the limitation is the community hospital, their ability to fund.
Hi, John. Good to see you again. Just this rural emergency hospital designation, I've sort of followed it with some interest, and at first thought it looked like a pretty good solution to preserve rural access to care. My sense is, though, the jury is still out on it. Would that be fair?
Certainly fair. And nationally, there's a debate on, whether it's better for a community. It's clearly viewed as kind of a less than hospital solution, but I'm supportive because in those communities I've mentioned, it's been protective. They at least have an emergency room and a primary care clinic in a way that had it not been for the new designation, they would have nothing.
And I would assume they have some type of relationship with a higher level of care somehow, so that they can say, okay, this person needs to go, and they get them there. And
That's actually part of the designation is the transfer agreements with the level 1 trauma centers and things of that nature.
Sure.
And so those do exist. We have felt for those that have gone to the new designation, and it increases transfer volume. So it's put a little pressure on those EMS services. But that's that makes sense that that would be a result. But those communities that have gone to REH say that it has been good for those communities.
Thank you.
Yes, sir.
Yeah, Dr. Ray Spearman, go ahead.
Yeah, first I want to thank John for the tremendous work he's doing in supporting the rural hospital system. He's a wonderful advocate, and we appreciate all the work you're doing, John. John, can you speak to the role of how telehealth is leveraging that technology to support the workforce in the rural community and in some cases expand it? It's been a tool that we've been able to leverage significantly in the last, post-COVID, certain as far as access to care. Thank you.
For sure. And thank you, Dr. Ross Spearman. We love telemedicine. We're a little bit careful to say it's not the silver bullet for everything, but we think it's a game changer for access to specialty physician services in particular, and mental health services in particular. So, for those communities that are geographically isolated, telemedicine is certainly part of the solution as we expand broadband access. But in my mind, it doesn't replace a good primary care physician or a well-trained nurse in that community.
Okay. Thank you so much, John. I appreciate that. That rural perspective always rounds it out to bring us all back to the heart of the issues. All right. So we are going to turn now to the Higher Ed Coordinating Board. And this person, Chad Quintero, is going to speak virtually. So he's going to be up on the monitor. And he's going to give us an update on the implementation of Senate Bill 25.
Hello, everyone. Can everybody hear me okay?
Yep.
Great. I am Chad Quintero Pulse, and I am Assistant Commissioner of Student Financial Aid Programs at the Texas Higher Education Coordinating Board. And I wanted to provide you an update on the 3 financial aid programs that were amended and funded through SB 25. There was a change to the nursing faculty loan repayment program, as well as the creation or recreation of the nursing scholarship and the nurse loan repayment programs. For the nursing faculty loan repayment program, and I apologize, before I move forward, I should mention that all of those changes in the bill were effective starting with the 24-25 academic year. And so we're preparing to make sure that all of those are in place this fall. So the nursing faculty loan repayment program, the legislature amended the statute to allow part-time nursing faculty to be eligible for the program. And so we have been working to make sure that those rules are in place and that the operational procedures will be in place for nursing faculty that are working during the 24-25 academic year. And the legislature already increased the funding for that program, more than doubling the funding from about 3 million to 7 million over the course of the biennium for the nursing faculty loan repayment program. I know that has, I've worked at the coordinating board for 9 years now, and that has been every legislative session something that I've seen attempted to add the part-time nursing faculty, and that was finally accomplished. Another thing, or two other things that occurred during SB 25 were the nursing scholarship program and the nurse loan repayment program. Those programs had not been funded in well over a decade. And during this last legislative session, $25 million was provided, divided equally between the two programs. So 12.5 million for scholarships and 12.5 million for the loan repayment programs. The nursing scholarship program, we went through negotiated rulemaking to develop the rules for the nursing loan for the nursing scholarship program. And we had a key emphasis on trying to make sure that the program provided as much flexibility for institutions as possible, because we know that different institutions have different focuses in terms of the populations that they educate, and wanted to make sure that there was the opportunity for each institution to really focus on its individual student population. Those rules will be taken to the July board meeting to request approval from the coordinating board so that we're ready to have those in place for the fall. The nursing scholarship program runs similar to other grant programs that we have in that they are provided as block grants to institutions, so that the institutions who participate receive a percentage of the funds that are available based on the percentage of eligible students that they educate, and then the institutions are able to make the decisions as to which students will receive the funding. And so we'll be spending the next couple months making sure that institutions fully understand how the program works, so that they will be ready to implement as soon as those rules become effective, so that students can start receiving that money this fall. We also have the nurse loan repayment program. And again, our focus in setting up the program was to focus on the greatest flexibility as possible. In talking to stakeholders and getting feedback from stakeholders, the decision was made to allow a wide swath of nurses to be eligible for the program because the shortages really occur across the board. There really wasn't any one particular type of nurse that we felt we could target through this program because the need is just so great across all areas. And so that program, the rules will also be going to the July board meeting for us to be able to request adoption, so that those will be in place for the fall. And really with any new program, we've got three major things that we have to do. We need rules so that we can run the program. We need technology so that we can actually administer the program. And then we need outreach to make sure that individuals are aware of the program. And so, as I mentioned, the rules will be going to the July board meeting. The technology for the nursing scholarship is already in place, and we're currently building the technology to have that ready by the end of August for the nurse loan repayment program, so that nurses will be able to start applying at the beginning of September. And then for the outreach, we are going to be spending the next couple months. I mentioned that we'll be working with institutions to make sure that they understand how to administer the nursing scholarship program so that they can start very quickly in getting that money out to students. And for the nurse loan repayment program, we are starting to work with various professional associations, connecting with licensing organizations, working to connect with institutions to make their students aware of the program, and doing everything we can to try to make sure that we've built up a demand for the program, so that in the fall we quickly see people start applying for the program. Those are the three main pieces, or those are the three funded pieces from SB 25 that Student Financial Aid Programs is administering: the Nursing Faculty Loan Repayment Program, the Nursing Scholarship, and the Nurse Loan Repayment Program. I'd be happy to answer any questions that you might have about these.
Anybody have any questions? Really appreciate that update, Chad.
You're welcome.
Thank you for calling in with that. And we will move on to our last presentation, and that is Elizabeth Mayer with the Higher Ed Coordinating Board, who will give us an academic and health affairs update.
Good afternoon. I'm going to go ahead and you heard about many of these programs so far, but I'm going to quickly kind of go through the programs, the grant programs that my division oversees pertaining specifically to nursing. So here's just kind of a rundown of the ones I'm going to run through. The Nursing Shortage Reduction Program, the Nursing Allied Health and Other NIGP, not to be confused with the other NIGP program, which was put in Rider, which was very confusing when we call the thing the same thing. Then the Minority Health and Research Education Grant Program, Emergency and Trauma Care Education Partnership Program. So I think, as has been kind of discussed already, nursing had very positive appropriations this legislative session. You can see 22, 23 allocations, and then the 24, 25. A couple of the programs had increases. There were two programs, the Minority Health Research and Education Program and the Nursing Allied Health and Other NIGP program. Both of those had stable allocations. Those are actually also tobacco funded allocations. But I'm going to go through each of these so you can kind of. Nursing Shortage Reduction Program. So this program has actually been in existence for quite some time, since 2001. And it's gone through different iterations. There were three kind of buckets for the program when it initially started. There was discussions, and then there was a work group that was conducted a couple of years ago. And then they decided they wanted one bucket. We didn't like the one bucket, so now we're back to three buckets for the allocation. And TNA's handout has the various tiers: the growth tier, production tier, and faculty tier, which kind of lays out kind of how much each bucket gets. But you can see there, it had received about 9 million in the prior biennium. And then for this fiscal year, we're doing about $22.7 million. And so we are actually in the middle of finalizing those awards, and we're going to be able to provide funding to 83 institutions for this year. So the NIGP, so this program, as I mentioned before, is tobacco funded. And it was established in 1999. It provides grant funding to eligible Texas institutions of higher education nursing programs that propose to address the shortage of registered nurses in Texas by developing or expanding new activities and projects that promote innovation and the preparation of initial RN licensure for students. So since 2000, the coordinating board has awarded approximately $46 million out of this bucket to 96 institutions. So the Minority Health Grant Program, this is the other tobacco funded program. So it was also established in 1999. It provides grant funding to Texas institutions of higher education to really conduct research or educational programs that address minority health issues, or form partnerships with minority organizations, colleges, or universities to conduct research and educational programs that address minority and health issues. So this program, as I mentioned, is tobacco funded and received about the same amount of funding from the prior biennium. Right. ETAP. So the Emergency and Trauma Care Program. So this program actually has two pieces. Oh, sorry. Actually has two pieces. So there's a GME component and a nursing component. So I'm just going to focus on the nursing component. So the program had been declining in funding since its peak in 2016, 2017. It did receive $3.9 million in 2022-23, but got an increase this last biennium for a total of $5.9 million. So this provides funding to support emergency and trauma care partnerships between hospitals and graduate professional nursing programs to increase the education and training experiences in emergency and trauma care for registered nurses pursuing graduate level education. And then since 2012, the coordinating board has, for the nursing component, has awarded $6.8 million to 652 graduate nursing positions. And then last is this NIGP, not to be confused with the other NIGP, which was just put in Rider. So this was really, I think, an opportunity for us to kind of look and really to some of the commissioners' comments about scalability and innovation to really see what we can do. So right now for this, we are actually partnering, that's just the Rider language, partnering with UT Health, who is providing a landscape analysis to kind of give us a lay of the land. And based upon kind of the outcomes and what we find from that, that will help give us some direction of what grants or what kind of topics we should be considering for the grant program moving forward. And that received $6 million for the biennium. So that's just kind of a rundown of the grant programs that our agency oversees, and happy to answer any questions. But as the commissioner said in his remarks, and is evident just based upon what I have provided, a lot of these have been around since like 1999, 2000, 2001. You know, I think all of the programs are incredibly grateful for these programs, much like GME and GME expansion. You know, I think they benefit from these programs, but are we keeping up kind of for what we need, right? Like we're a little bit behind, and I think in terms of, you know, if we want to have more qualified applicants and be able to enroll more folks in the program, like what should be, we keep funneling money in, but what does that need to look like? Or do we need to do something different? So.
Thank you very much, Elizabeth. Any questions? Okay. That is our last presentation for today. And I'm gonna, I think, wrap things up here, but I do want to make a few remarks. First of all, I do want to thank the governor for putting together this project and sending us down this path to be able to really take a look at this very long-standing and serious issue. A lot of incredible work has been done, Senator Kolkhorst and others, towards this goal, and we're looking forward to being able to complement that and really move the process into the future. I want to thank the commissioner and the folks from the Higher Ed Coordinating Board. Their staff have really been amazing to put all this together on this timeline. And all the task force, advisory committee members, all of you, and I appreciate it. I'm just thanking you way up front for what we're going to be asking you to do. And then the rest of the stakeholders too, because we can't really operate in a vacuum without you. The first work group meeting for work group 1 is scheduled for July 8th. So we'll be getting the invitations out for that as soon as possible, starting tomorrow, really. If you're on work group 1, you should already be considered invited. So we're gonna get that process started. I think it's gonna be a very intensive day and really look at a lot of these issues around allied healthcare professionals and then around the data and I think probably maybe some retention issues and some other things that we would take on in this work group. So thank you all very much for being here and in the Workforce Commission. Thank you all. We'll be including you as we keep going forward and those local boards. Really great stories of how we put our stick-to-itiveness together and come up with solutions that meet our community. So thanks, everybody.